Okay, let's unpack this. Imagine the controlled chaos in an emergency room, that focused intensity where every detail matters. A patient arrives, a 64-year-old woman, to be precise, who's taken a nasty fall. She's cradling her left arm, her elbow flexed, her right hand supporting it, wincing with severe pain radiating from her left shoulder. But it's more than just the agony. When the clinicians look, they see something striking, a clear loss of the normal rounded contour of her shoulder. There's a slight swelling visible just below her left clavicle, a subtle but significant clue. And then, as they meticulously test her cutaneous sensibility, tracing patterns across her skin, they find something truly perplexing, something severe. She has sensory deficits that map out a precise, alarming picture, involving the skin of the back of her arm extending all the way down to the elbow. Her lower lateral arm, also down to the elbow, shows a loss of sensation. The middle of the posterior surface of her forearm, right down to the wrist, is affected. And in her hand, the lateral half of the dorsal surface and the dorsal surface of the lateral 3.5 fingers, proximal to the nail beds, are all numb. This isn't just pain. It's a complex anatomical puzzle. How does a clinician even begin to piece together what's going on here beyond the immediate undeniable pain to arrive at a diagnosis that could profoundly impact her recovery?
Well, this scenario, much like the most intricate challenges in clinical practice, demands not just knowledge, but a profound and incredibly detailed understanding of the human body. Today, we're not just skimming the surface. We're going on a true deep dive into the upper limb. We'll trace every bone, every muscle, every nerve, and every vessel to master this information as if we were elite professionals in the field ourselves. Our mission is to dissect this complexity, to move beyond just recognizing symptoms to truly understanding the why and how behind them. This isn't for trivia, it's for profound life-saving insight and for you to truly grasp the incredible engineering of your own body.
And for you, our listener, this deep dive is your shortcut to being genuinely well-informed, to truly master this intricate system. It's for anyone captivated by the marvel of human movement, the sheer resilience of the body, and the intricate connections that allow us to interact with the world around us. By the end of this journey, you'll not only understand precisely what happened to our patient and the incredible complexity involved in her injury, but you'll also gain a whole new appreciation for the engineering marvel that is your own arm and hand. We're going to give you those aha moments that transform how you see and use your body every single day. So let's jump right in and start with the foundational scaffolding of the upper limb, the bones. In our patient's case, that initial striking observation, the loss of the normal rounded curvature of her left shoulder, is a monumental clue. It immediately tells us something isn't where it's supposed to be. It screams skeletal displacement. It's the first major ripple in the water, indicating a significant shift in the underlying bony framework.
Precisely. And the shoulder region itself is a complex architectural marvel, a ballet of bones designed for immense mobility. We begin our deep dive with the shoulder girdle, a crucial component that connects the upper limb to the axial skeleton. This girdle comprises two vital bones, the clavicle and the scapula. The clavicle, commonly known as the collarbone, is a fascinating S-shaped bone that you can easily feel running horizontally across the root of your neck. It's entirely subcutaneous, meaning, it lies just beneath the skin. What's truly unique about the clavicle is that it's the very first bone in the human body to begin the process of ossification, or bone formation, starting surprisingly early in fetal development. Functionally, it acts as a light, but incredibly strong strut. It's the only bony connection between the upper limb and the trunk, providing a stable platform for the scapula and allowing for the wide, sweeping range of movement that defines our arm.
Right, and it's a crucial connection that, while enabling mobility, also makes it quite vulnerable, doesn't it? Can you elaborate on its features and clinical vulnerabilities?
Certainly. The clavicle has two distinct ends. Medially, there is the blunt sternal extremity, which articulates with the manubrium of the sternum via an articular disc, forming the sternoclavicular joint. Laterally, we find the flattened acromial extremity, which articulates with the acromion process of the scapula, forming the acromioclavicular joint. On its inferior surface, near the acromial end, there's a roughened area known as the conoid tubercle, which serves as a critical attachment point for the conoid ligament, a part of the stronger corticoclavicular ligament. Unfortunately, this vital strut is also the most commonly fractured bone in the entire body. The mechanism is usually direct trauma, such as a fall directly onto the shoulder, or an indirect force transmitted up the arm, like a fall on an outstretched hand. The weakest point, and thus the most common site of fracture, is typically at the junction of its middle and outer thirds. When a fracture occurs, the displacement of the bone fragments can be quite dramatic, largely due to the powerful pull of surrounding muscles. The lateral fragment, unsupported by the rib cage, is usually depressed by the sheer weight of the arm and pulled medially and forward by strong adductor muscles like the pectoralis major. Meanwhile, the medial end is often tilted upward by the sternocleidomastoid muscle, pulling on its proximal attachment. A severe fracture here can lead to various complications. The expanding callus or new bone formation during healing can sometimes impinge upon the supraclavicular nerves, leading to persistent and often debilitating neck pain. Furthermore, a condition known as thoracic outlet syndrome can occur if the interval between the clavicle and the first rib is narrowed. This can compress the critical neurovascular bundle, specifically the brachial plexus, subclavian artery, and subclavian vein as they pass into the upper limb, causing pain, numbness, and weakness.
Wow, that's a lot of potential trouble for one bone. Moving on to the scapula, or shoulder blade. It's this large, flat, triangular bone, almost like a shield, resting on the posterior chest wall, typically spanning from the second to the seventh ribs. It's got three distinct borders: superior, medial or vertebral, and lateral or axillary in three angles. Superior, inferior, and lateral. That inferior angle, by the way, is easily palpable and sits around the level of the seventh rib or the spine of the seventh thoracic vertebra, which is a key anatomical landmark.
Indeed. The scapula's dorsal, or posterior surface, is famously divided by a prominent triangular ridge called the spine of the scapula. This spine divides the surface into two fossae, the supraspinous fossa above and the infraspinous fossa below. The spine itself extends laterally and merges into the broad, flat acromion, which forms the highest point of the shoulder and articulates with the clavicle. Anteriorly, there's the coracoid process, a thick beak-like structure that projects anterolaterally and is palpable deep to the deltoid muscle. The lateral angle of the scapula, sometimes called the head of the scapula, features the glenoid cavity. This is a shallow, pear-shaped, articular surface designed for the head of the humerus, and it's deepened slightly by a fibrocartilaginous rim called the glenoid labrum, enhancing stability. We also have two important notches. The suprascapular notch, located on the superior border, which is typically bridged by the superior transverse scapular ligament. Through this structure, the suprascapular artery passes over the ligament, while the suprascapular nerve passes under it. A classic anatomical mnemonic is Army over, Navy under, to remember their relative positions. Further laterally, the sphenoglenoid notch, also known as the greater scapular notch, connects the supraspinous and infraspinous fossa, allowing passage for the suprascapular nerve and vessels. Fractures of the scapula are relatively rare compared to the clavicle because the scapula is so mobile and well protected by a thick layer of surrounding muscles, effectively splinting it. They usually result from severe, high-energy trauma. However, conditions like dropped shoulder or winged scapula are not due to bone fracture, but rather paralysis of the muscles that stabilize the scapula, such as the trapezius for dropped shoulder or the serratus anterior for winged scapula. When these muscles are compromised, the scapula loses its normal balance, protruding posteriorly and disrupting the smooth mechanics of shoulder movement.
That's a truly comprehensive look at the shoulder girdle. Now for the arm bone itself, the humerus, the longest bone in your upper limb, it's a solitary bone of the arm, or brachium, connecting proximally with the scapula at the shoulder joint and distally meeting the radius and ulna at the elbow joint. It's conventionally divided into three main regions: the proximal extremity, the elongated body or shaft, and the distal extremity.
The proximal extremity of the humerus is particularly crucial, especially in the context of our patient's shoulder injury. It includes the round, smooth head, which forms about 1/3 of a sphere and is perfectly designed to articulate with the shallow glenoid cavity of the scapula. Lateral to the head, you have the greater tubercle, a large, prominent elevation that serves as the attachment point for three of the four muscles of the rotator cuff: the supraspinatus, infraspinatus, and teres minor. Medially and anteriorly, there's the smaller but equally important lesser tubercle, which provides attachment for the fourth rotator cuff muscle, the subscapularis. Surrounding the articular surface of the head is the anatomical neck, a constricted region where fractures are relatively rare but can occur, particularly in the elderly, often compromising the blood supply to the humeral head. More distally, and perhaps even more clinically significant, is the constricted area known as the surgical neck. This is a very common fracture site, and it has critical relations. The axillary nerve and the anterior and posterior circumflex humeral vessels are intimately associated with this region, making them highly vulnerable to damage during a fracture or dislocation. Separating the two tubercles anteriorly is the deep intertubercular groove, also known as the bicipital groove, which provides a protected pathway for the tendon of the long head of the biceps brachii muscle.
So many important structures clustered together in such a small area, making it incredibly vulnerable. Moving down the humerus, the body or shaft has the deltoid tuberosity, a rough and triangular elevation located on its midshaft. This is where the powerful deltoid muscle, the main abductor of the arm, attaches. Just behind and spiraling laterally from this tuberosity is the radial groove, often called the spiral groove. This shallow depression is absolutely critical because it provides a direct, close contact pathway for two vital structures, the radial nerve and the profunda brachivessels. This intimate relationship means that these structures are highly vulnerable to injury, especially in midshaft fractures of the humerus.
And at the distal extremity of the humerus, we find even more intricate anatomy forming the elbow joint. Here we have the epicondyles, the small lateral epicondyle, which serves as a common attachment point for the common extensor tendon of the forearm muscles, and where inflammation can lead to tennis elbow, and the larger, more prominent, and easily palpable medial epicondyle. The ulnar nerve crosses the posterior surface of this medial epicondyle in a shallow sulcus, making it notoriously susceptible to injury, famously causing that funny bone sensation when hit or compressed. Articulating with the forearm bones are two distinct surfaces: the rounded capitulum, located laterally, which connects with the head of the radius, and the pulley-shaped trochlea, located medially, which articulates with the ulnar trochlear notch. Above these articular surfaces are three fossa, which accommodate the forearm bones during elbow movement. The coronoid fossa anteriorly, which receives the ulnus coronoid process during full flexion. The radial fossa, also anteriorly, which receives the head of the radius during full flexion. And the deep olecranon fossa posteriorly, which receives the ulnus olecranon process during full extension, locking the elbow straight.
Okay, now let's tie all this detailed osteology back to our patient and the clinical significance of these humeral fractures, especially relevant to her specific shoulder dislocation and sensory deficits. Fractures of the humeral head, for instance, can occur during shoulder dislocations, with the glenoid labrum sometimes getting entrapped in the defect created by the humeral head. The greater tuberosity, where crucial rotator cuff muscles attach, can be fractured by direct trauma, displaced during a dislocation, or even avulsed pulled off by a strong contraction of the supraspinatus muscle. If it remains displaced after a shoulder reduction, open surgery might be necessary to realign it and restore rotator cuff function. A lesser tuberosity fracture might accompany a posterior dislocation, given the attachment of the subscapularis here.
And this is where a patient's case becomes strikingly clear. A fracture of the surgical neck of the humerus is very common, resulting from a direct blow or a fall on an outstretched hand. As we noted, this is precisely where the axillary nerve and the anterior and posterior circumflex humeral vessels are at high risk of damage. Our patient suffered a shoulder dislocation, which involves significant force and displacement, often placing immense stress on the surgical neck region, directly explaining her axillary nerve damage. Furthermore, fractures of the humeral shaft, especially inferior to the deltoid tuberosity, are extremely dangerous for the radial nerve as it lies intimately within that spiral groove. Significant trauma, such as a severe dislocation or an associated fracture, can easily compromise the radial nerve. This anatomical vulnerability provides the direct explanation for her radial nerve damage. Beyond that, distal end fractures, such as supracondylar fractures, are common in children from falls on an outstretched hand with a flexed elbow. These can risk damage to the median, radial, and ulnar nerves, as well as the brachial artery, potentially leading to a devastating complication called Volkmann's ischemic contracture. This is where a lack of blood supply causes ischemic necrosis of forearm muscles, which are then replaced by fibrous tissue that contracts, leading to a permanent severe deformity of the hand. Even an avulsion of the medial epicondyle, particularly common in children, can lead to ulnar nerve injury. This entire humerus, a single bone, is a minefield of potential neurovascular complications when subjected to trauma, underscoring the vital need for precise anatomical knowledge.
Truly, a complex bone with far-reaching implications. Let's move down to the forearm, with the two parallel bones, the radius and the ulna. The radius is the bone on the lateral or thumb side of your forearm. Its expanded round head proximally articulates with the capitulum of the humerus and the radial notch of the ulna, held securely in place by the annular ligament, which acts like a collar. Just distal to that is the neck, and then the prominent radial tuberosity, where the powerful biceps brachii muscle inserts. The shaft of the radius widens distally, and its medial border forms the interosseous border, providing a key attachment for the interosseous membrane. Distally, the radius has the ulnar notch for the head of the ulna, a prominent styloid process laterally, and a carpal articular surface that articulates directly with the scaphoid and lunate bones of the wrist.
In contrast, the ulna lies on the medial or little finger side of the forearm, characterized by its large hook-shaped proximal end, perfectly designed to articulate with the humerus. The olecranon is the easily palpable most proximal end, forming the point of the elbow and serving as the powerful insertion for the triceps brachii muscle. Anteriorly, there's the coronoid process, which, along with the olecranon, forms the large trochlear notch designed to grasp the humerus's trochlea. On the lateral side of the coronoid process, the radial notch articulates with the head of the radius, and the ulnar tuberosity anteriorly is the insertion for the brachialis muscle. The ulna shaft tapers distally, unlike the radius, and its posterior aspect is subcutaneous and easily palpable along its entire length. Unlike the radius, the ulna's head is small and rounded distally, and it doesn't directly articulate with the carpal bones. Instead, it's separated from the wrist joint by an articular disc, and it has its own styloid process, a pointed projection posterolaterally.
Fractures of these forearm bones are also very common, often with quite specific patterns. Radial head fractures, for instance, frequently result from falls on an outstretched hand, driving the head forcefully against the capitulum of the humerus and potentially splitting it. Neck fractures are more common in children. Shaft fractures, whether isolated or combined with an ulna fracture, can have significant displacement of the fragments due to the powerful and often opposing pulls of muscles, like the supinator, biceps brachii, pronator quadratus, and brachioradialis.
And sometimes injuries involve both bones in a combined, complex fashion, creating specific fracture dislocation patterns that clinicians learn to recognize. For example, in Montague's fracture, a force applied from behind the forearm fractures the shaft of the ulna, leading to an associated anterior dislocation of the radial head and rupture of the annular ligament. Galazzi's fracture, conversely, involves a proximal radius fracture coupled with a distal ulna dislocation. Olecranon process fractures are also frequent, typically from falls directly onto a flexed elbow or from a direct blow, with the powerful triceps muscle often displacing the olecranon fragments. Distal radius fractures are especially common, particularly in those over 50 due to osteoporosis. Colles fracture is the most prevalent type, resulting from a fall on an outstretched hand, which displaces the distal fragment of the radius posteriorly and superiorly, creating a characteristic dinner fork deformity visible on clinical examination. Smith's fracture is essentially a reversed Colles, where a fall in the back of the hand causes the distal fragment to be displaced anteriorly. And let's not forget olecranon bursitis, a chronic inflammation of the bursa located over the olecranon, often from repeated trauma or prolonged pressure, commonly referred to as student's elbow.
Finally, we arrive at the wrist and hand, a truly intricate and beautifully engineered set of bones that enable incredible dexterity. We have the 8 carpal bones, arranged in 2 rows, proximal and distal, forming the compact carpus. These bones, which aren't fully ossified until around age 12, also form the floor and walls of the carpal tunnel. There's a handy mnemonic I learned to keep them straight. Some lovers try positions that they cannot handle.
A classic and very effective mnemonic. Let's break those down. In the proximal row, from lateral to medial, thumb side to little finger side, we have the scaphoid, lunate, triquetrum, and pisiform. The scaphoid is the largest and most lateral bone in this row. It's boat-shaped and forms a key part of the floor of the anatomical snuff box. It's frequently fractured, especially in young adults, often leading to poor union and a significant risk of a vascular necrosis, meaning bone death, due to an interrupted blood supply, which is a serious complication due to its unique and precarious blood supply. The lunate, or moon-shaped bone, sits centrally and is prone to dislocation, which can often involve the median nerve. The triquetrum is triangular, and the pisiform is a small, pea-shaped sesamoid bone, uniquely embedded within the tendon of the flexor carpi ulnaris muscle.
Then the distal row, also from lateral to medial. The trapezium, trapezoid, capitate, and hamate. The trapezium is absolutely crucial for hand function. It forms a saddle joint with the first metacarpal, allowing for the thumb's incredible mobility and range of motion. Truly, the thumb swings on the trapezium. The capitate is the central and largest carpal bone, named for its head-like shape, and it's a key bone for transmitting forces from the third metacarpal. The hamate, the most medial bone in this row, is distinguishing for its prominent hamulus, or hook, a vital attachment for the flexor retinaculum.
Following the carpals are the 5 metacarpal bones, which form the body of the hand and are numbered 1 to 5, with the thumb being number 1. Each metacarpal has a base, which articulates with the carpals, a shaft or body, and a rounded head, which forms your knuckles or the metacarpophalangeal joints. The first metacarpal, for the thumb, is the shortest and most mobile, uniquely rotated relative to the others. Fractures here can result from direct violence, like a boxer's fracture, which is typically an oblique fracture of the neck of the fifth or sometimes fourth metacarpal, often from punching. Bennett's fracture is a clinically significant fracture involving the base of the thumb metacarpal. It's an oblique fracture that enters the carpometacarpal joint, leading to inherent instability. Finally, we have the 14 phalanges, the bones of your digits. The thumb has two, a proximal and a distal phalanx, while the other four digits each have three, a proximal, middle, and distal phalanx. Phalangeal fractures are very common, typically resulting from direct injury to the fingers. This entire bony framework, from shoulder girdle to fingertips, is designed for a remarkable balance of stability and extraordinary dexterity, which, of course, also leaves it exquisitely vulnerable to the forces of trauma.
Now that we've meticulously laid out the skeletal foundation, let's zoom out a bit and look at the broader functional regions of the upper limb. Remember, the upper limb is essentially a multi-jointed lever, an incredible biomechanical system, and its primary ultimate function is to maneuver the hand with precision and power. It's anatomically organized into distinct regions: the shoulder, arm, cubital fossa, forearm, wrist, and hand. And as we'll delve deeper, each of these regions or compartments houses its own specialized collection of muscles, nerves, and blood supply, all working in exquisite synchronicity. It's a marvel of organized complexity that allows for our incredible range of interaction with the world.
Indeed. Let's begin our regional exploration with the pectoral region, which forms the anterior aspect of the shoulder and also encompasses a significant portion of the anterior thoracic wall. Although its muscles connect with and function as part of the upper limb, this region also critically houses the breasts. While the breasts are not strictly part of the limb itself, their anatomical location means their blood supply and, most importantly, their lymphatic drainage are intrinsically and critically linked to the axilla, making them highly relevant to any comprehensive study of the upper limb's neurovascular and lymphatic pathways.
Right. And the breasts are, as you said, of immense clinical importance, not just functionally, but pathologically. They are specialized accessory skin glands, present in both sexes, structured with a complex system of ducts and secretory alveoli, embedded within connective tissue and fat. In females, during puberty, they enlarge dramatically under hormonal influence, primarily due to fat deposition and the elongation and branching of the duct system. During pregnancy, this system proliferates further. Secretory alveoli develop, vascularity increases significantly, and the areola, the pigmented area surrounding the nipple, typically darkens. After weaning, they undergo involution, returning to a more inactive state, and post-menopause, they atrophy due to the absence of ovarian hormones, potentially shrinking or becoming more pendulous as glandular tissue is replaced by fat and connective tissue. We also see conditions like witch's milk in newborns, caused by residual maternal hormones, which typically resolve spontaneously.
The vascular supply to the breast is quite rich, derived from perforating branches of the internal thoracic and intercostal arteries, as well as the lateral thoracic and thoracochromial branches of the axillary artery. However, what is truly critical, particularly from a clinical and life-saving standpoint, is the intricate network of lymph drainage. This knowledge is paramount for understanding the pathways of cancer metastasis, especially in breast carcinoma. The lateral quadrants of the breast, which account for approximately 60% of all breast cancers, primarily drain into the anterior axillary or pectoral group of lymph nodes, situated just posterior to the pectoralis major muscle. Conversely, the medial quadrants drain into the internal thoracic group of nodes, which pierce the intercostal spaces. A few lymphatic vessels also follow the posterior intercostal arteries, and some even communicate across the midline to the opposite breast or inferiorly to the anterior abdominal wall.
So if a carcinoma originates in those lateral quadrants, it tends to spread first to those axillary nodes, which thankfully are surgically more accessible. But if these primary lymphatic pathways are obstructed or overwhelmed by malignant cells, the cancer can then spread to the opposite breast, into the abdomen, or even superiorly into the neck nodes. And if cancer cells gain entry into the blood vessels, that leads to distant bone metastases, a much more dire prognosis. Clinicians perform meticulous breast examinations, looking for symmetry, any suspicious swelling, or nipple retraction, which can be a telltale sign of carcinoma pulling on the lactiferous ducts and surrounding fibrous septa, causing characteristic skin dimpling. Mammography, using low-dose X-rays, is a vital screening tool for early detection of tumors or cysts, often detecting lesions just a few millimeters in size. Supernumerary nipples or polythelia, and issues like retracted or inverted nipples, micromastia, small breasts, macromastia hypertrophy, and gynecomastia, male breast enlargement, are all variations or anomalies encountered in clinical practice.
From an embryological perspective, the breasts develop from a milk ridge, an ectodermal thickening that initially extends from the axilla to the groin in the embryo, but in humans, it only persists and develops further in the pectoral region. This developmental process, if incomplete, can lead to anomalies such as polythelia, the presence of supernumerary nipples along the embryonic milk line. A retracted or inverted nipple, for example, results from a failure in the complete development of the lactiferous ducts, making it prone to infection. The fibrous septa within the breast, often called suspensory ligaments of Cooper, are also crucial. If a serous carcinoma, a type of aggressive breast cancer, or an abscess applies traction to these septa, it causes the characteristic skin dimpling or peau d'orange appearance. Infections, like a breast abscess during lactation, are often localized by these septa, necessitating a radial incision for drainage to follow the ductal anatomy and minimize damage. It's also worth noting that male breast carcinoma, though rare, accounting for about 1% of breast cancers, is often overlooked and can have a poor prognosis due to rapid metastasis into the thorax.
Have to deep dive into an area that's so interconnected with the upper limb, particularly through its lymphatic drainage. Let's now turn to the scapular region, the posterior aspect of the shoulder. Here, numerous structures connect to and function with the upper limb. A key anatomical feature here, directly relevant to our patient's case of shoulder dislocation and nerve damage, is the quadrangular space. This is a critical intermuscular space located just below the shoulder joint itself.
The quadrangular space is precisely defined by specific anatomical boundaries, making its contents particularly vulnerable. Superiorly, its boundary is formed by the inferior margins of the subscapularis and teres minor muscles, along with the shoulder joint capsule. Inferiorly, it's bounded by the superior border of the teres major muscle. Medially, it's defined by the long head of the triceps brachii muscle. And laterally, the surgical neck of the humerus completes its boundaries. Its significance for our patient cannot be overstated because two incredibly important structures emerge through this very space: the axillary nerve and the posterior circumflex humeral vessels. Damage or compression in this region, such as from a humeral head dislocation, precisely what our patient experienced, or a fracture of the surgical neck of the humerus, directly explains the common injuries to the axillary nerve. This anatomical bottleneck is a high-risk zone.
Next, let's explore the axilla, commonly known as the armpit. This is a pyramid-shaped space that serves as a vital anatomical passage, a true crossroads for nerves, vessels, and lymphatics as they travel between the root of the neck and the upper limb. The apex of this pyramid points superiorly into the root of the neck, bounded by the clavicle, the superior border of the scapula, and the first rib. The base of the pyramid is formed by the skin and the anterior and posterior axillary folds, which you can easily feel.
And its walls are just as distinct. Anteriorly, we have the pectoralis major, pectoralis minor, and subclavius muscles. Posteriorly, the subscapularis, latissimus dorsi, and teres major muscles form the wall. Medially, it's the first 5 ribs, their intercostal spaces, and the serratus anterior muscle. Laterally, the corca brachialis, biceps brachii, and the bicipital groove of the humerus define the boundary. Within this space, all embedded in a protective matrix of fat, are the axillary artery and all its branches, the axillary vein and its tributaries, a comprehensive network of lymph vessels and lymph nodes which drain the upper limb, breast, and much of the trunk, and the entire brachial plexus. The pectoralis minor muscle is a key anatomical landmark within the axilla as it crosses in front of the axillary artery, dividing it conveniently into 3 subregions: proximal, deep, and distal to the muscle. This division is not arbitrary. It's clinically useful for describing arterial segments and understanding the organization of lymph drainage. The clavipectoral fascia, a strong sheet of deep fascia located deep to the pectoralis major, encloses the subclavius and pectoralis minor muscles and contributes to the suspensory ligament of the axilla. It's pierced by important structures like the lateral pectoral nerve, the cephalic vein, branches of the thoracomial artery, and lymphatics. Clinically, the axillary sheath, which is a fascial extension that encloses the axillary vessels and the brachial plexus, is a common target for brachial plexus nerve blocks, where anesthetic is injected to temporarily numb the entire upper limb for surgery or pain management.
Moving down to the arm, or brachium, the segment from the shoulder to the elbow. This region is ingeniously organized into 2 major osteofascial compartments by deep fascia and 2 medial and lateral intermuscular septa, which extend from the deep fascia to the humerus. You have an anterior compartment and a posterior compartment. The anterior compartment typically houses the musculocutaneous, median, and ulnar nerves, along with the brachial artery and the basilic vein, though the radial nerve also enters its lower part after traversing the posterior compartment.
While the posterior compartment is primarily home to the radial nerve and the profunda brachii-vessels, the ulnar nerve also passes through its medial aspect after piercing the medial intermuscular septum. Each of these compartments has its specific set of muscles, nerves, and arteries, ensuring an efficient and specialized function for the different actions of the arm. This compartmentalization is a recurring theme in the upper limb, offering both functional specialization and, as we'll see, clinical vulnerabilities.
The elbow region, specifically the cubital fossa, is a fascinating and incredibly important triangular depression located at the anterior aspect of the elbow. Despite its small size, it's a major thoroughfare, a vital passage for numerous structures traveling between the arm and forearm. It's bounded laterally by the medial border of the brachioradialis muscle, medially by the lateral border of the pronator teres muscle, and its base is formed by an imaginary line connecting the humeral epicondyles. The floor of this fossa is formed by the supinator muscle laterally and the brachialis muscle medially, and its roof is surprisingly superficial, composed of skin, superficial fascia, and the bicipital aponeurosis, a strong, flat tendon that helps protect its contents.
The contents of the cubital fossa, arranged from medial to lateral, are absolutely crucial for clinical diagnosis and intervention. They are the median nerve, the bifurcation of the brachial artery into its two major terminal branches, the ulnar and radial arteries, the strong tendon of the biceps brachii muscle, and the radial nerve, which quickly divides into its superficial and deep branches here. Their close proximity within this confined space makes this area a key landmark for understanding injury patterns, nerve blocks, and the precise location of pulses.
Next, the forearm, or antebrachium, extending from the elbow to the wrist. Like the arm, it's also divided into distinct osteofascial compartments, anterior, lateral, and posterior. This division is created by the deep fascia, the robust interosseous membrane, which unites the shafts of the radius and ulna and provides crucial attachment for many forearm muscles, and fibrous intermuscular septa.
These tightly packed compartments are highly clinically relevant, especially concerning conditions like forearm compartment syndrome. In these confined spaces, often only expansible distally, any significant edema or swelling, commonly from soft tissue injury or prolonged compression, can rapidly increase pressure. This increased pressure can then compress blood vessels and nerves within the compartment, leading to ischemia and potential permanent damage. Early signs are critical for diagnosis. Altered skin sensation, pain disproportionate to the injury, intense pain on passive stretching of the affected muscles, tenderness over the compartment, and a diminished or absent capillary refill. Prompt surgical incision, known as fasciotomy, is often critical to relieve the pressure and prevent irreversible muscle and nerve damage. Another severe condition linked to these compartments is Volkmann's ischemic contracture, which often follows distal humerus, radius, or ulnar fractures, particularly in children. A spasm or compression of the brachial artery can cause ischemic necrosis of the flexor and extensor muscles, with flexors being more commonly affected. These damaged muscles are then replaced by non-contractile fibrous tissue that contracts, leading to a severe permanent contracture and deformity of the hand and wrist. Understanding these compartments is paramount to managing such limb-threatening emergencies.
Let's move to the wrist, or carpus, a complex array of 8 small bones that, along with converging tendons, arteries, and nerves, make it a pivotal anatomical region and a common site for injury. Here we find 2 crucial strong bands of deep fascia, the flexor retinaculum and the extensor retinaculum. The flexor retinaculum, a significant thickening of deep fascia across the front of the wrist, effectively converts the concave anterior surface of the wrist into the infamous osteofascial carpal tunnel.
The flexor retinaculum has very specific attachments that define this tunnel. Medially, it attaches to the pisiform bone and the hook of the hamate. Laterally, it attaches to the scaphoid tubercle and the trapezium bones. This carpal tunnel is an absolutely critical passage, transmitting the median nerve and numerous flexor tendons into the hand. Superficial to the flexor retinaculum, meaning outside the tunnel, you'll find the flexor carpial noris tendon, the ulnar nerve, the ulnar artery, and the palmar cutaneous branches of both the ulnar and median nerves. Deep inside the carpal tunnel itself, arranged from medial to lateral, are the 4 flexor digitorum superficialis tendons, and deep to those, the 4 flexor digitorum profundus tendons, both groups sharing a common synovial sheath. Also inside are the median nerve and the flexor pollicis longus tendon, each enclosed in its own synovial sheath, and the flexor carpi radialis tendon.
On the posterior aspect of the wrist, the extensor retinaculum, a similar thickening of deep fascia, serves to hold the long extensor tendon securely in place. Unlike the flexor retinaculum, it forms 6 separate, distinct tunnels, each lined with a synovial sheath for the various extensor tendons to glide smoothly. Superficial to this retinaculum, you'll find the dorsal cutaneous branch of the ulnar nerve, the basilic and cephalic veins, and the superficial branch of the radial nerve.
The carpal tunnel, as we've discussed, is a prime example of anatomical arrangement leading to significant clinical consequences. It's a notoriously tightly packed space. Any condition that decreases its size or causes swelling within it, thereby compressing its contents, leads to carpal tunnel syndrome. This often involves thickening of the synovial sheaths surrounding the tendons or arthritic changes in the carpal bones. Clinically, this manifests as burning pain, tingling, or pins and needles sensations along the distribution of the median nerve to the palmar aspect of the lateral 3.5 fingers, typically accompanied by weakness or atrophy of the thenar muscles. Crucially, a key diagnostic point is that the palmar cutaneous branch of the median nerve passes superficial to the flexor retinaculum, so there is typically no paresthesia or sensory loss over the thenar eminence itself. Surgical incision of the flexor retinaculum, a procedure called carpal tunnel release, typically provides dramatic relief. Another important landmark in this region is the anatomic snuff box, a triangular skin depression visible on the posterolateral aspect of the wrist when the thumb is extended. Its floor allows for easy palpation of the scaphoid bone, a common fracture site, and you can also feel the pulsations of the radial artery within it.
Finally, we move to the hand, or manus, the distal end of the upper limb, and arguably the most functional and finely tuned organ of the human body. Its immense significance largely hinges on the pincer-like opposable action of the thumb, which sets us apart in terms of dexterity. The skin of the palm is uniquely thick, hairless, and firmly bound down by fibrous bands to the underlying palmar aponeurosis, featuring characteristic flexure creases that don't actually overlead joints. The dorsum of the hand, however, has thin, hairy, and much more mobile skin. The deep fascia of the palm is particularly specialized. Centrally, it forms the strong, triangular palmar aponeurosis, which not only protects underlying tendons, but also enhances grip by creating a firm, unyielding surface.
Indeed, the palmar aponeurosis is critical not just for normal function but also pathologically. Its localized thickening and contracture lead to deprutrine contracture, a genetic condition that causes fibrous bands to form, limiting hand function and typically pulling the ring and little fingers into a fixed flexion deformity. Surgical division of these bands or enzyme injections are common treatments. The fascial spaces of the palm, the thenar space, the mid-palmar space, and the lumbrical canals are normally potential spaces filled with loose connective tissue. However, their well-defined boundaries become clinically vital in limiting the spread of infection within the hand, such as from suppurative tenosynovitis, infection of tendon sheaths, or penetrating wounds. And the finger pulp spaces, which are closed fascial compartments anterior to the terminal phalanx of each digit, are subdivided by numerous septa and contain a digital artery branch that supplies the diaphysis of the phalanx. Infections here, known as felons, are relatively common and serious. The high pressure generated by inflammation within these confined spaces can compromise the blood supply to the terminal phalanx, risking necrosis and bone loss, even though the epiphysis, the growth plate, is typically spared as it has a separate blood supply.
With the intricate bony framework and regional landscape now understood, let's truly bring motion to the limb by exploring the muscles that generate all its incredible power and precision. It's truly amazing how muscles originating in your chest are actually considered part of your upper limbs toolkit, acting on the shoulder girdle and humerus to create movement. These include the pectoralis major and minor and the subclavius. Clinically, a congenital absence of the pectoralis major, especially its sternocostal origin, results in noticeable weakness in adduction and medial rotation of the shoulder, highlighting its critical role.
That's right. And moving posteriorly, the superficial back muscles like the trapezius, latissimus dorsi, levator scapulae, and rhomboids also functionally belong to the upper limb. They form a crucial link, connecting the shoulder girdle directly to the vertebral column and thus influencing scapular and arm movements. Within the scapular region itself, we have intrinsic muscles that connect the scapula directly to the humerus, primarily responsible for the more refined abduction, adduction, and rotational movements of the arm.
And central to the shoulder's stability and its wide range of motion is the incredibly important rotator cuff. It's a group of 4 critical muscles: the subscapularis, supraspinatus, infraspinatus, and teres minor. Their tendons literally fuse with and reinforce the underlying capsule of the shoulder joint, and their collective tone is absolutely essential for holding the head of the humerus securely and centrally within the shallow glenoid cavity of the scapula during all those wide-ranging dynamic movements. It's their continuous, synchronized action that truly stabilizes an inherently unstable joint. However, it's important to note that the rotator cuff mechanism is deficient inferiorly, making that part of the capsule the least supported, and thus a site of potential weakness and vulnerability.
That inferior deficiency is a key point for injuries, as it's often the pathway for shoulder dislocations. Lesions of the rotator cuff are a very common cause of shoulder pain, frequently due to age-related wear and tear or from excessive repetitive overhead use, common in athletes involved in sports like baseball, tennis, or swimming. The supraspinatus tendon is by far the most frequently injured, often experiencing friction against the overlying acromion and the subacromial bursa, which normally minimizes this friction. Clinically, this can manifest as subacromial bursitis, inflammation of the bursa, supraspinatus tendinitis, inflammation of the tendon, or pericapsulitis, inflammation of the joint capsule, all characterized by shoulder pain. A classic diagnostic sign is a painful arc during the middle range of abduction, usually between 60 and 120 degrees, where the inflamed area impinges on the acromion. Extensive tears often require surgical repair, while chronic, less severe injuries are managed non-surgically. A complete rupture of the supraspinatus tendon is quite disabling. The patient is typically unable to initiate abduction of the arm. The supraspinatus's specific role is to hold the humeral head firmly in the glenoid fossa and start the abduction process. If the arm is passively assisted past that initial 15 degrees of abduction, then the powerful deltoid muscle can usually take over and complete the movement. This highlights the precise sequential action of these muscles.
That's a crucial clinical distinction. Moving into the arm itself, the muscles are again divided into those two osteofascial compartments we mentioned earlier. The anterior compartment contains the primary flexors of the shoulder and elbow and muscles responsible for powerful supination. These are all primarily innervated by the musculocutaneous nerve. A prime example, and one of the most recognizable muscles, is the biceps brachii. It's a powerful elbow flexor, weak shoulder flexor, but its most powerful action is supination, especially against resistance. Think about using a corkscrew to open a bottle with your right hand, that powerful twisting motion, or driving a screw that's your biceps in action, supinating powerfully.
And in the posterior compartment of the arm, you have the extensors of the shoulder and elbow, primarily the triceps brachii muscle, which has 3 heads. These are all predominantly supplied by the radial nerve. An interesting clinical note for the biceps brachii: its long head tendon travels uniquely within the shoulder joint capsule itself. In advanced osteoarthritis of the shoulder, osteophytic outgrowths, bone spurs, can cause chronic friction, leading to fraying or even rupture of this tendon, resulting in pain and weakness.
Down on the forearm, another region with 3 osteofascial compartments: anterior, lateral, and posterior. The anterior compartment muscles are mainly responsible for flexion of the wrist and digits and pronation of the forearm. They're primarily innervated by the median and ulnar nerves. This compartment has a superficial group of muscles, all originating from a common flexor tendon on the medial epicondyle of the humerus, including the flexor carpi ulnaris, palmaris longus, flexor carpi radialis, and pronator teres. Deeper to them are the intermediate flexor digitorum superficialis and deep flexor digitorum profundus, flexor pollicis longus, and pronator quadratus groups.
The lateral compartment muscles, like the brachioradialis and extensor carpi radialis longus, are primarily supplied by the radial nerve. The brachioradialis is an interesting exception to the general extensor theme of the radial nerve supply. It's actually a significant elbow flexor, particularly effective in rapid movements. The posterior compartment muscles primarily focus on extension of the wrist and digits and supination of the forearm, all also supplied by the radial nerve. They are arranged into superficial and deep groups, with the superficial group having a common origin from the lateral epicondyle of the humerus.
Sometimes people are congenitally missing the palmaris longus muscle on one or both sides. It's absent in about 10% of the population. But this typically causes no functional disability due to its relatively weak action and the presence of other stronger flexors. On the flip side, tennis elbow, or lateral epicondylitis, is a very common and painful condition caused by partial tearing or degeneration of the superficial extensor muscle's origin from the lateral epicondyle, characterized by pain and tenderness radiating down the lateral forearm, especially with gripping or wrist extension. It's not just for tennis players, but also for violinists, carpenters, or anyone with a repetitive wrist extension.
We also encounter stenosing tenosynovitis, more commonly known as de Quervain's tenosynovitis. This condition results from friction and inflammation between the tendons of the abductor pollicis longus and extensor pollicis brevis muscles as they pass through a common fibrous sheath at the radial styloid process, leading to swelling, fibrosis, and restricted, painful thumb movement. In severe cases, surgical incision of the constricting sheath is necessary. Another notable injury related to tendons is the rupture of the extensor pollicis longus tendon, which can occur after a distal radius fracture due to a roughening of the dorsal tubercle causing excessive friction, or as a complication of rheumatoid arthritis, where inflammatory processes weaken the tendon.
Now, onto the hand, a masterpiece of fine motor control in an area of immense anatomical and clinical complexity. The hand muscles are categorized as either extrinsic, meaning they originate in the forearm and insert into the hand, or intrinsic, meaning they both originate and insert within the hand itself. These intrinsic muscles are organized into 5 key osteofascial compartments: the thenar eminence, for the thumb, the hypothenar eminence, for the little finger, the central mid-palmar compartment, the interosseous compartment, and the dorsal extensor compartment. The anterior surface of each finger has strong, fibrous flexor sheaths that act like tunnels, holding the long flexor tendons securely in place and preventing bowstringing during flexion. These tunnels are thick over the phalanges and thin over the joints.
And within these fibrous sheaths are the synovial flexor sheaths, which are absolutely crucial for allowing the long flexor tendons to glide smoothly and effortlessly with minimal friction as the fingers flex and extend. The flexor digitorum superficialis and profundus tendons, which flex the 4 medial fingers, share a common synovial sheath at the wrist and palm, with the medial part of this sheath extending all the way to the little finger, while the lateral part typically stops mid-palm. The flexor pollicis longus tendon, which flexes the thumb, has its own separate synovial sheath. These sheaths are supplied with blood vessels via delicate folds of synovial membrane called vincula longa and brevia. These synovial sheaths are highly clinically relevant. They can become infected, a condition called suppurative tenosynovitis, usually from a penetrating wound like a pinprick to the finger. The infected sheath becomes distended with pus. The finger typically assumes a semiflexed, swollen, and painful posture, with extreme pain on any attempt at passive extension. The increased pressure within the sheath can rapidly compromise the tendon's vital blood supply via the vincula, leading to tendon necrosis, rupture, or scarring, and permanent loss of function. Infections can also spread from these digital sheaths into the palmar fascial spaces, or from the continuous thumb, radial bursa, and little finger, ulnar bursa, sheaths into the forearm space of corona, creating a much larger limb-threatening infection.
The long flexor tendons themselves have a truly unique and elegant insertion pattern, often called the buttonhole effect. The flexor digitorum superficialis tendon, as it approaches the middle phalanx, splits into 2 slips. The flexor digitorum profundus tendon then passes through this split, like a button through a buttonhole. The 2 slips of the superficialis tendon then reunite briefly before inserting into the sides of the middle phalanx. The profundus tendon, having passed through, continues on to insert into the base of the distal phalanx. This mechanism allows the superficialis to flex the proximal interphalangeal joint and the profundus to flex the distal interphalangeal joint. But sometimes a localized swelling or nodule develops on a flexor tendon, causing it to catch on a narrowing in the fibrous flexor sheath, creating a trigger finger or trigger thumb characterized by a palpable, sometimes painful snapping sensation as the tendon forces its way through.
A small superficial muscle called the palmaris brevis, located outside these main compartments, lies in the hypothenar eminence. When it contracts, it subtly corrugates the skin at the base of the hypothenar eminence, which improves grip by creating a firmer, less slippery surface. The 4 lumbrical muscles, uniquely, arise from the tendons of the flexor digitorum profundus in the palm. They are remarkable for their seemingly contradictory actions. They flex the metacarpophalangeal joints while simultaneously extending the interphalangeal joints of digits 2 through 5. Similarly, the 8 interosseous muscles, 4 palmar and 4 dorsal, also flex the metacarpophalangeal joints and extend the interphalangeal joints. Crucially, the palmar interossea adduct the digits, bring them towards the middle finger, while the dorsal interossei abduct them, spread them away from the middle finger. A useful mnemonic to remember their specific actions is pe versus dia, palmar adduct, dorsal abduct.
That mnemonic certainly makes it much easier to remember their actions. And the long extensor tendons, primarily from the extensor digitorum muscle, don't just attach directly to the bones. Instead, they fan out over the dorsum of the hand and join a complex fibrous structure called the extensor expansion or extensor hood on the posterior surface of each finger. This expansion is a key player, as it receives the tendons of the lumbrical and interosseous muscles. This complex anatomical arrangement is what allows those seemingly contradictory actions of the lumbricals and interossei to happen. They transmit their force through the expansion to extend the interphalangeal joints. Damage here can lead to specific deformities like mallet finger, where avulsion of the extensor tendon insertion into the distal phalanx leads to a loss of active extension, causing the fingertip to droop. Another is boutonniere deformity, an avulsion of the central slip of the extensor tendon from the middle phalanx, causing a characteristic flexion of the proximal interphalangeal joint and hyperextension of the distal interphalangeal joint.
Finally, we have the intrinsic muscles of the thumb and little finger grouped into their respective eminences. The thenar eminence for the thumb consists of the abductor pollicis brevis, flexor pollicis brevis, and the opponens pollicis. The opponens pollicis is absolutely critical for true opposition, which is not just flexion but also involves a medial rotation of the first metacarpal across the palm, allowing the pulp of the thumb to touch the tips of other fingers, forming that unique pincer-like action. Without it, delicate manipulation and tool use would be severely compromised. The hypothenar eminence for the little finger includes the abductor digiti minimi, flexor digiti minimi brevis, and opponens digiti minimi, which rotates the fifth metacarpal slightly, assisting in cupping the palm. The adductor pollicis, with its two heads, is also vital for the thumb, providing a strong adduction force crucial for a powerful grip. These intrinsic muscles collectively give the hand its incredible dexterity, precision, and strength.
Let's delve even deeper into the communication network, the nerves that orchestrate all this intricate movement and sensation in the upper limb. This is where we directly return to our patient's perplexing, yet precisely mapped symptoms. Remember her severe sensory deficits involving the skin of the back of her arm down as far as the elbow, the lower lateral surface of the arm down to the elbow, the middle of the posterior surface of the forearm as far as the wrist, the lateral half of the dorsal surface of the hand, and the dorsal surface of the lateral 3.5 fingers proximal to the nail beds. This was specifically attributed to axillary and radial nerve damage. We are now going to dissect why her specific pattern of sensory loss points to these very nerves, and what their individual courses reveal about their vulnerability.
Exactly. Before we dive into the major players of the brachial plexus, let's briefly mention the spinal accessory nerve, cranial nerve XLA. It's unique because it's the only cranial nerve that actually supplies a muscle of the upper limb, providing motor innervation to the trapezius muscle, with cervical nerve supplying its sensory input. It's often vulnerable to injury in the posterior triangle of the neck during surgical procedures or trauma. However, the real powerhouse for the vast majority of upper limb innervation is the brachial plexus.
The brachial plexus, that unbelievably complex network of nerves, originating from the anterior rami of spinal nerves C5 through T1. It's truly vital for all upper limb innervation, providing not only sensory input to skin and joints and precise motor control to muscles, but also sympathetic vasomotor influence over blood vessels and secretomotor supply to sweat glands. I still vividly remember the mnemonic we used to keep its intricate parts straight. Robert Taylor drinks cold beer for roots, trunks, divisions, cords, and branches. It's a lifesaver for navigating this complex wiring diagram.
A classic and indispensable mnemonic that helps visualize the intricate structure. Let's trace it. The roots, as you mentioned, are the anterior rami of spinal nerves, C5, C6, C7, C8, and T1. These roots then converge to form three main trunks: the upper trunk from C5 to 6, the middle trunk from C7, and the lower trunk from C8 T1. Each of these trunks then divides into an anterior division and a posterior division. These 6 divisions then regroup to form 3 chords: the lateral cord, the medial cord, and the posterior cord, named, crucially, for the anatomical relationship to the second part of the axillary artery. Finally, these cords give rise to the 5 major terminal branches: the musculocutaneous nerve, the median nerve, the ulnar nerve, the axillary nerve, and the radial nerve. It's important to remember that the entire brachial plexus, along with the axillary artery and vein, is enclosed within a fascial sleeve called the axillary sheath, which is clinically highly significant as the target for brachial plexus nerve blocks. Injecting anesthetic here can temporarily block all sensation and motor function in the entire upper limb, making it invaluable for surgical procedures or pain management.
It's incredible how a single spinal segment can contribute nerve fibers to multiple peripheral nerves, highlighting the redundancy and complexity built into this system. The branches off the plexus are numerous and highly specific. From the roots, you have the dorsal scapular nerve, supplying the levator scapulae and rhomboids, and the long thoracic nerve, C5 to 7, supplying the serratus anterior muscle, the boxer's muscle, which is particularly vulnerable due to its superficial course along the lateral chest wall. The upper trunk gives off the small nerve to subclavius, C5-6, and the suprascapular nerve, C5-6, which innervates the supraspinatus and infraspinatus muscles, and also provides sensory innervation to the shoulder joint itself.
Then, the lateral cord branches into the lateral pectoral nerve, which supplies the pectoralis major muscle, and the musculocutaneous nerve, which is a major nerve for the arm flexors and sensation to the lateral forearm. It also contributes the lateral root of the median nerve. The medial cord gives rise to the medial pectoral nerve, which supplies both the pectoralis minor and pectoralis major, and the medial cutaneous nerves of the arm and forearm, providing sensation to these medial areas. It also gives off the ulnar nerve, a major nerve for forearm and hand muscles and sensation to the medial hand, and the medial root of the median nerve. And the largest cord, the posterior cord, branches into the upper and lower subscapular nerves, supplying the subscapularis and teres major muscles, the thoracodorsal nerve to the latissimus dorsi, the axillary nerve, which supplies the deltoid and teres minor and sensation to the lateral arm, and the radial nerve, which is the major nerve for arm and forearm extensors and provides extensive cutaneous innervation to the posterior arm, forearm, and hand.
All these nerves, of course, contribute to the precise innervation of the skin, creating what we call cutaneous nerves and dermatomes. Dermatomes are specific areas of skin primarily supplied by a single spinal nerve segment. The posterior rami of spinal nerves supply the scapular region. The supraclavicular nerves, C3 to 4, cover the point of the shoulder and part of the deltoid. The medial cutaneous nerve of the arm, T1, and the intercostobrachial nerve, T2, cover the axilla and the medial aspect of the arm. The remaining areas of the upper limb skin are then covered by the numerous branches of the brachial plexus. Dermatomes are organized in a roughly sequential pattern, with C3 to 6 along the lateral upper limb, C7 primarily on the middle finger, and C8, T1, T2 along the medial limb.
This dermatomal map is not merely academic, it's clinically vital, forming the basis for neurological examinations. For example, pain can be referred to the shoulder region from other distant areas, such as the diaphragmatic pleura or peritoneum, via the phrenic and supraclavicular nerves. So conditions like pleurisy, peritonitis, a subphrenic abscess, or even gallbladder disease can all cause pain that a patient perceives in their shoulder, even if the shoulder joint itself is perfectly normal. This highlights the incredible interconnectedness of nerve pathways and the importance of considering referred pain and diagnosis.
Speaking of connections, injuries to the brachial plexus itself can be devastating, leading to profound loss of function. Upper lesions, known as Herb Duchenne palsy, or sometimes called the waiter's tip posture, typically result from excessive traction on the C5-6 roots, often from a difficult delivery where the baby's head is pulled too forcefully, or a traumatic fall on the shoulder that separates the head from the shoulder. This paralyzes muscles supplied by these roots, such as the supraspinatus, infraspinatus subclavius, coracobrachialis, biceps brachialis partially, deltoid, and teres minor. The affected limb hangs limply by the side, medially rotated, adducted, and with the forearm pronated, resembling a waiter asking for a tip. Sensory loss is typically found over the lower deltoid and the lateral forearm.
Conversely, lower lesions, known as Klumpke's palsy, typically involve traction on the T1 root, often from excessive arm abduction, such as falling from a height and grabbing onto something with an outstretched arm. This specifically affects the small intrinsic muscles of the hand, which are primarily supplied by the ulnar and median nerves, resulting in a characteristic claw hand appearance. Hyperextension of the metacarpophalangeal joints and flexion of the interphalangeal joints, particularly in the ring and little fingers. Sensory loss occurs along the medial arm, forearm, and hand, especially if C8 is also involved. These lower lesions can also be caused by pressure from a cervical rib, an extra rib in the neck, or by metastases from lung cancer in the apex of the lung, which can directly impinge on the lower trunk of the brachial plexus. And then there's long thoracic nerve injury, often caused by blows or pressure to the posterior triangle of the neck or lateral chest wall, such as during a radical mastectomy. This leads to paralysis of the serratus anterior muscle, resulting in a winged scapula, where the medial border of the scapula protrudes posteriorly, making it extremely difficult to rotate the scapula and thus abduct the arm above 90 degrees.
Let's now focus on the individual terminal nerves, particularly those central to our patient's symptoms. The musculocutaneous nerve, originating from C5-7, emerges from the lateral cord of the brachial plexus. It then takes a distinctive course, piercing the coracobrachialis muscle, and continues to run between the biceps brachii and brachialis muscles in the anterior compartment of the arm. It then emerges at the lateral margin of the biceps tendon, pierces the deep fascia just above the elbow, and continues as the lateral cutaneous nerve of the forearm. It provides motor branches to the coracobrachialis, biceps brachii, and brachialis muscles, and cutaneous branches that supply the skin on the front and lateral aspects of the forearm. It also provides articular branches to the elbow joint. It's rarely injured due to its protected position deep within the arm muscles, but a high injury would result in paralysis of the biceps and corcobrachialis, weakened brachialis, and sensory loss along the lateral forearm. Wounds in the forearm could sever its cutaneous branch, causing only sensory loss.
Now, the median nerve from C5T1 is aptly named as it courses along the median axis of the upper limb. It has a unique characteristic. It gives off no branches in the axilla or the arm, save for a small vasomotor nerve supplying the brachial artery. It begins its journey lateral to the brachial artery in the upper arm, then crosses to the medial side in the midarm. It traverses the cubital fossa, passing deep to the bicipital aponeurosis, then descends into the forearm between the two heads of the pronator teres muscle, and continues distally between the flexor digitorum superficialis and profundus muscles. In the lower forearm, it emerges lateral to the flexor digitorum superficialis tendon at the wrist. Critically, it then passes deep to the flexor retinaculum through the confined carpal tunnel, where it finally enters the palm. In the forearm, the median nerve is the major motor nerve to most of the anterior compartment muscles, except for the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. It gives off the anterior interosseous nerve, which specifically supplies the flexor pollicis longus, pronator quadratus, and the lateral half of the flexor digitorum profundus, as well as articular branches to the wrist and distal radial trunner joints. It also provides a palmar cutaneous branch in the lower forearm, which travels superficial to the flexor retinaculum to supply sensation to the skin of the lateral palm.
So that palmar cutaneous branch is an important detail for distinguishing a carpal tunnel injury. In the hand, the median nerve acts as the minor motor nerve to intrinsic hand muscles, supplying the thenar muscles, the abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis via its recurrent branch, often called the million-dollar nerve, due to its critical motor function to the thumb. Its palmar digital branches also supply the first and second lumbricals. These same palmar digital branches provide sensation to the palmar aspect of the lateral 3½ fingers, thumb, index, middle, and half of the ring finger, and the distal half of their dorsal surfaces, around the nail beds.
Therefore, a median nerve lesion has profound clinical consequences, though our patient did not have this specific injury. It can be injured by supracondylar humerus fractures, penetrating wounds just proximal to the flexor retinaculum at the wrist, or most famously, by compression within the tightly packed carpal tunnel, leading to carpal tunnel syndrome. The motor effects result in a characteristic ape-hand deformity. There is paralysis of the pronators and most long flexors of the wrist and fingers, except the flexor carpi ulnaris and medial half of the flexor digitorum profundus. The forearm remains supine, and wrist flexion is weak and deviates to the ulnar side due to the unopposed flexor carpi ulnaris. Crucially, no flexion is possible at the interphalangeal joints of the index and middle fingers, and when the patient attempts to make a fist, these fingers remain straight. The thumb is extended and adducted, unable to flex or oppose, leading to a flattened thenar eminence due to muscle paralysis and wasting. The first and second lumbricals are paralyzed, causing the index and middle fingers to lag in flexion. This flattened, weakened hand, resembling that of a great ape, is severely disabling. Sensory effects involve loss over the lateral half of the palm, due to the palmar cutaneous branch, which is often spared in carpal tunnel syndrome, but not in more proximal lesions, the palmar aspect of the lateral 3½ fingers, and the distal dorsal surfaces of those same fingers. The total area of anesthesia is less than the theoretical distribution due to overlapping innervation. However, the most serious disability from a median nerve injury is the combined loss of thumb opposition and critical sensory loss over the lateral fingers, crippling the delicate pincer action that is fundamental to hand function. Additionally, vasomotor changes can occur, making the skin warmer and drier due to arteriolar dilation and loss of sweating, loss of sympathetic control, and trophic changes such as dry, scaly skin, cracked nails, and atrophy of the finger pulp in long-standing cases.
And the ulnar nerve, originating from C8 and T1, takes a more medial path. It also gives off no branches in the axilla or the arm, except for articular branches to the elbow joint. It descends medial to the brachial artery in the upper arm, then famously pierces the medial intramuscular septum to descend in the posterior compartment, covered by the medial head of the triceps. Its critical exposed point is where it passes behind the medial epicondyle of the humerus, that funny bone spot, before entering the forearm between the two heads of the flexor carpi ulnaris muscle. In the forearm, it descends between the flexor carpi ulnaris and flexor digitorum profundus muscles, and becomes superficial at the wrist, passing between the flexor carpi ulnaris and flexor digitorum superficialis tendons. It then passes superficial to the flexor retinaculum, just lateral to the pisiform bone, to enter the palm, where it divides into superficial and deep branches. In the forearm, the ulnar nerve provides muscular branches to the flexor carpial naris and the medial half of the flexor digitorum profundus. It also gives off a palmar cutaneous branch in the mid-forearm, which travels superficial to the flexor retinaculum to supply sensation to the skin of the medial palm. Crucially, it provides a posterior or dorsal cutaneous branch in the distal third of the forearm. This branch winds around the ulna, passes superficial to the extensor retinaculum, and supplies sensation to the medial third of the dorsum of the hand, including the dorsal surface of the medial 1½ fingers, and sometimes 2½. Importantly, this branch does not supply the distal dorsal part of the fingers.
In the hand, the ulnar nerve's superficial branch is primarily cutaneous, providing sensation to the palmaris brevis muscle and the palmar aspect of the medial 1½ fingers, including their nail beds. This branch travels in the subcutaneous tissue, medial to the ulnar artery, within a fibro-osseous canal called Guyon's tunnel, making it susceptible to compression. However, its deep branch is the major motor nerve to most intrinsic hand muscles, supplying all the hypothenar muscles, abductor digiti minimi, flexor digiti minimi brevis, and opponens digiti minimi. All 4 palmar and 4 dorsal interossae, the 3rd and 4th lumbricals, and both heads of the adductor pollicis. The ulnar nerve is most commonly injured at the elbow due to its exposed position behind the medial epicondyle, often with fractures, or at the wrist due to its superficial position, making it vulnerable to cuts or stab wounds. Elbow injuries affect its entire territory, while wrist injuries spare the forearm muscles and affect only the distal hand territory.
A lesion of the ulnar nerve also has significant motor and sensory effects, though less disabling than a median nerve injury in terms of fine motor control. Motor-wise, it leads to a characteristic claw hand, because the small intrinsic hand muscles are paralyzed, with the notable exceptions of the thenar muscles and the first 2 lumbricals, which are supplied by the median nerve. The patient will have weakness of wrist flexion with abduction and ulnar deviation due to the paralyzed flexor carpial naris. There's no marked flexion of the terminal phalanges of the ring and little fingers because the medial half of the flexor digitorum profundus is paralyzed. The patient will be unable to adduct or abduct their fingers, and thumb adduction is impossible due to the paralyzed adductor pollicis. This is demonstrated by Froment's sign, where the patient compensates by using the flexor pollicis longus to grasp paper, causing the thumb interphalangeal joint to hyperflex. The metacarpophalangeal joints become hyperextended, and the interphalangeal joints flexed, with the clawing most pronounced in the 4th and 5th fingers, because the 1st and 2nd lumbricals are still intact.
There is also marked wasting of the hypothenar eminence and hollowing on the dorsum of the hand due to the wasting of the interossi muscles.
Sensory effects from an ulnar nerve injury at the elbow would cause loss of sensation over the anterior and posterior medial third of the hand and the medial 1½ fingers. A wrist injury, however, typically spares the posterior cutaneous branch, so sensory loss is confined to the palmar medial third of the hand and the medial 1½ fingers, including the dorsal, middle, and distal phalanges of those same fingers. Although disabling, ulnar nerve lesions are generally considered less disabling than median nerve injuries because the intact lateral sensation via the median nerve and a reasonable pincer grip with the thumb and index finger remain. Vasomotor changes are also present, leading to warmer, drier skin due to arteriolar dilation and loss of sweating.
Now, to the axillary nerve, originating from C5-6, which is absolutely central to our patient's case and her specific sensory deficits. It originates from the posterior cord of the brachial plexus and takes a deep and backward course, passing through the quadrangular space along with the posterior circumflex humeral artery. Here, it's an intimate relationship with the inferior aspect of the shoulder joint capsule and the surgical neck of the humerus. After passing through this critical space, it divides into terminal branches. It supplies articular branches to the shoulder joint. Its anterior terminal branch supplies the deltoid muscle and the skin over the lower part of the deltoid, and its posterior terminal branch supplies the teres minor muscle, some additional deltoid branches, and it continues as the upper lateral cutaneous nerve of the arm.
And this is precisely why the axillary nerve is so critical for our patient's diagnosis. It is highly vulnerable to injury in specific scenarios, most commonly in shoulder dislocations, which our patient suffered, by compression in the quadrangular space, from crutch pressure in the axilla, or, very commonly, from surgical neck fractures of the humerus. Damage here causes paralysis and rapid wasting of the powerful deltoid muscle, leading to impaired shoulder abduction, as the supraspinatus becomes the only other muscle capable of initiating abduction. While Tay's minor paralysis is difficult to recognize clinically due to the presence of other medial rotators, the critical diagnostic sign is the loss of skin sensation over the lower half of the deltoid muscle, precisely the area supplied by the upper lateral cutaneous nerve of the arm. This perfectly matches a significant part of our patient's initial sensory findings on her lower lateral arm.
And then the radial nerve, originating from C5T1, the largest branch of the brachial plexus, is truly a workhorse, being the sole motor nerve to the posterior compartments of both the arm and forearm. And it also provides extensive cutaneous innervation. In the axilla, it travels deep, behind the axillary artery. Here it supplies the long and medial heads of the triceps brachii muscle and gives off the posterior cutaneous nerve of the arm, which supplies the skin on the back of the arm down to the elbow.
It then enters the posterior compartment of the arm, winding around the back of the humerus in the radial groove, or spiral groove, where it lies directly in close contact with the shaft of the humerus, accompanied by the profunda brachii-vessels. This is another extremely crucial area for our patient's specific injury pattern. In the radial groove, it supplies the lateral and medial heads of the triceps and the anconeus muscle. It also gives off the lower lateral cutaneous nerve of the arm, supplying skin over the lateral and anterior lower arm, and the posterior cutaneous nerve of the forearm, supplying skin to the mid-back of the forearm. It also gives articular branches to the elbow. As it reaches the cubital fossa, it pierces the lateral intermuscular septum to enter the anterior compartment of the arm, where it divides into its superficial and deep branches near the lateral epicondyle. The superficial branch is primarily cutaneous, continuing its descent under the brachia radialis muscle, lateral to the radial artery. It then leaves the artery distally, winds around the radius, passes superficial to the extensor retinaculum, and gives rise to dorsal digital nerves that supply sensation to the lateral 2/3 of the dorsum of the hand and the dorsal surface of the proximal phalanges of the lateral 3½ fingers. The deep branch, or posterior interosseous nerve, is purely motor. It winds around the neck of the radius, piercing the supinator muscle to enter the posterior forearm compartment, where it supplies all the extensor muscles in the posterior forearm.
A radial nerve lesion is also highly relevant to our patient's specific sensory deficits. It can be injured in several locations. In the axilla, it's vulnerable to crutch pressure, sometimes leading to Saturday night palsy if an arm is hung over a chair for prolonged periods, or by fractures and dislocations of the proximal humerus, where the nerve can be excessively stretched by downward displacement. It's most commonly injured in the radial groove of the humerus during shaft fractures of the humerus, from callus formation during healing, or from prolonged pressure against the operating table or a tourniquet. The deep branch can also be damaged in proximal radius fractures or radial head dislocations.
Motor effects of a radial nerve lesion in the axilla or radial groove are devastating and characteristically lead to wrist drop. This is paralysis of the triceps and camerius and the long extensors of the wrist, fingers, and thumb, resulting in an inability to extend the elbow, wrist, or fingers. The wrist falls into a flexed position due to the unopposed action of the flexor muscles, making it extremely disabling, as one cannot grip strongly with a flexed wrist. The brachioradialis and supinator muscles are also paralyzed, though the biceps can still supinate. If the injury is in the radial groove, sparing the triceps and anconeus origins, the patient can still extend the shoulder and elbow, but will still present with wrist drop. Importantly, if only the deep branch is injured, motor loss to the extensors will occur, but wrist drop will not because the extensor carpi radialis longus, which is innervated more proximally, will keep the wrist extended.
As for sensory effects, an axillary lesion of the radial nerve results in a small but distinct loss of sensation over the posterior lower arm, a narrow strip on the back of the forearm, and a variable area on the lateral dorsum of the hand, including the dorsal roots of the lateral 3½ fingers. If the damage is in the radial groove, the sensory loss is similar, but perhaps less extensive. A deep branch lesion, being purely motor, causes no cutaneous loss. The superficial radial nerve division, if severed, causes sensory loss over a variable small area on the dorsal hand and the dorsal roots of the lateral 3½ fingers. This comprehensive sensory loss pattern, particularly on the back of her arm, the middle of the posterior forearm, and the lateral dorsal hand, perfectly explains our patient's sensory symptoms, directly pointing to damage to her radial nerve.
To complete our nerve overview, it's worth noting the tendon reflexes and their segmental innervation, which are quick and invaluable clinical tests to assess the integrity of specific spinal cord segments and peripheral nerves. The biceps brachii tendon reflex, when tapped, tests the integrity of spinal cord segments C5 and C6. The triceps tendon reflex tests C6, C7, and C8, and the brachioradialis tendon reflex tests C5, C6, and C7. These simple tests provide valuable and immediate insights into neurological function.
Now that we understand the incredibly intricate nervous network that controls sensation and movement, let's move on to the supply lines, the vital vasculature that keeps the entire upper limb nourished, functional, and alive. It all begins with the subclavian artery in the root of the neck, a major arterial trunk that then continues its journey as the axillary artery, serving as the main blood supply to the entire upper limb.
The axillary artery itself embarks on quite a journey through the axilla, starting at the lateral border of the first rib and ending at the lower border of the teres major muscle, where it seamlessly transitions into the brachial artery. Crucially, it runs in extremely close proximity with the cords of the brachial plexus and is, in fact, enclosed with them within the axillary sheath. The pectoralis minor muscle, as it crosses in front of the axillary artery, conveniently divides it into three distinct parts, which is not just an arbitrary anatomical division, but a clinically useful way to describe its relations and its branches.
So let's break down those three parts of this vital artery. The first part of the axillary artery, extending from the lateral border of the first rib to the upper border of pectoralis minor, lies posteriorly to the pectoralis major muscle and the overlying skin. The cephalic vein characteristically crosses anteriorly to it. Posteriorly, it's intimately related to the long thoracic nerve, laterally to the three cords of the brachial plexus, and medially to the axillary vein. Its only branch, which is often small and variable, is the highest thoracic artery, supplying the upper parts of the pectoralis muscles.
The second part of the axillary artery is situated deep to the pectoralis minor muscle. Anteriorly, it's covered by both the pectoralis minor and pectoralis major muscles. Posteriorly, it lies in front of the posterior cord of the brachial plexus, the subscapularis muscle, and the anterior aspect of the shoulder joint capsule. The lateral cord of the brachial plexus is positioned lateral to it, while the medial cord and the axillary vein are medial. This part gives off two distinct branches. First, the thoracoacromial artery, a short, stout trunk that immediately divides into four terminal branches: pectoral, acromial, deltoid, and clavicular branches, which supply the pectoral muscles and the acromioclavicular region. Second, the lateral thoracic artery, which runs inferiorly along the lateral chest wall, supplying the serratus anterior muscle and often contributing to the blood supply of the breast.
Finally, the third part, extending from the lower border of pectoralis minor to the lower border of teres major. Here, it's anteriorly related to the pectoralis major for a short distance, and then the medial root of the median nerve characteristically crosses anteriorly to it. Posteriorly, it sits on the subscapularis, latissimus dorsi, and teres major muscles, with the axillary and radial nerves also lying behind it, making them vulnerable in this region. Laterally, you'll find the coracobrachialis, biceps, and humerus, along with the lateral root of the median nerve and the musculocutaneous nerve. Medially, it's related to the ulnar nerve, the axillary vein, and the medial cutaneous nerve of the arm.
This third part gives off three vital branches. The subscapular artery is a large vessel that descends along the lateral border of the subscapularis and then divides into two major branches. The circumflex scapular artery, which curls around the axillary border of the scapula to supply muscles on the posterior scapula, and the thoracodorsal artery, which descends along the latissimus dorsi muscle. And critically, for our patient's case, the anterior and posterior circumflex humeral arteries are also branches here. These arteries wind around the surgical neck of the humerus, forming an anastomosing circle that provides collateral circulation to the shoulder joint. The posterior circumflex humeral artery is the larger of the two and, as we discussed, passes through the quadrangular space with the axillary nerve. This intimate anatomical relationship further highlights the extreme vulnerability of the axillary nerve in scenarios like shoulder dislocations and fractures of the surgical neck, reinforcing its direct role in our patient's injury.
That arterial anastomosis, or network of collateral connections around the shoulder joint, is incredibly important. Given the extreme mobility of the shoulder, the axillary artery can get kinked or temporarily occluded during certain movements or injuries. So, this vital collateral circulation, a network of connections between branches of the subclavian artery and the axillary artery, ensures continuous and sufficient blood flow to the entire upper limb, no matter the arm's position or any potential compression of the main vessel.
Exactly. From the subclavian artery, you have contributions from the suprascapular artery and a deep branch of the superficial cervical artery. From the axillary artery itself, the subscapular artery, particularly its circumflex scapular branch, along with the anterior and posterior circumflex humeral arteries, complete this intricate network. This anastomosis is so vital that if the axillary artery needs to be surgically ligated, it's absolutely critical to perform the ligation proximal to the origin of the subscapular artery to maintain adequate collateral flow to the entire upper limb. Ligation distal to this point would severely compromise blood flow.
Moving down the arm, the brachial artery is the direct continuation of the axillary artery, commencing at the lower border of the teres major. It supplies the entire arm, both its anterior and posterior compartments, and is the major arterial highway of the brachium. It finally terminates at the neck of the radius by dividing into its two major terminal branches, the radial and ulnar arteries. It's quite superficial in parts of its course, overlapped by the coracobrachialis and biceps muscles, and the median nerve characteristically crosses it from lateral to medial in the midarm. It lies on various muscles as it descends, first on the long head of the triceps, then the coracobrachialis, and finally the brachialis.
Its branches include several muscular branches supplying the arm muscles, a nutrient artery to the humerus, and 4 major branches that contribute significantly to the rich collateral circulation around the elbow joint, ensuring blood flow even during extreme elbow flexion or injury. The profunda brachii, or deep brachial artery, is a large branch that accompanies the radial nerve in the spiral groove of the humerus, supplying the triceps muscle and anastomoses with the radial recurrent artery. The superior ulnar collateral artery follows the ulnar nerve behind the medial epicondyle and anastomoses with the posterior ulnar recurrent artery, and the inferior ulnar collateral artery passes anterior to the medial epicondyle, anastomosing with the anterior ulnar recurrent artery. These networks are crucial bypass routes.
In the forearm, the ulnar artery, which is typically the larger of the two terminal branches of the brachial artery, descends through the medial aspect of the anterior forearm. Proximally, it runs deep to the superficial flexor muscles, but distally it becomes more superficial, lying between the tendons of the flexor carpi ulnaris and flexor digitorum superficialis. This superficial position, just lateral to the pisiform bone at the wrist, makes it an ideal site for taking the ulnar pulse. It then enters the palm superficial to the flexor retinaculum, along with the ulnar nerve, and forms the superficial palmar arch.
Its branches in the forearm are numerous. They include several muscular branches, the anterior and posterior ulnar recurrent branches, which contribute to the elbow anastomosis, and the common interosseous artery. The common interosseous artery is a short, stout trunk that quickly divides into the anterior interosseous artery and the posterior interosseous artery. These interosseous arteries supply the deep muscles of the forearm, the radius, ulna, and the interosseous membrane itself. In the hand, the ulnar artery, after entering the palm superficial to the flexor retinaculum, gives off a deep palmar branch and then continues as the superficial palmar arch. This arch anastomoses with the superficial palmar branch of the radial artery and gives rise to 3 common palmar digital arteries, which then bifurcate into proper palmar digital arteries supplying the fingers. The deep palmar branch of the ulnar artery then joins with the radial artery to complete the deep palmar arch.
The radial artery, which is typically the smaller terminal branch of the brachial artery, descends through the lateral aspect of the anterior forearm. Proximally, it runs deep to the brachioradialis muscle. In the mid-forearm, it's medial to the superficial radial nerve, and distally, it lies directly on the anterior surface of the radius, positioned between the tendons of the brachioradialis and flexor carpi radialis. This easily accessible location, lateral to the flexor carpi radialis tendon, makes it the ideal and most common site for taking the radial pulse. It then takes a distinctive course, winding around the lateral aspect of the wrist to reach the posterior surface of the hand, specifically entering the floor of the anatomical snuff box, before diving deep into the palm to form the deep palmar arch.
Its forearm branches include muscular branches, the radial recurrent artery for the elbow anastomosis, and the superficial palmar branch, which contributes to completing the superficial palmar arch by joining the ulnar artery. In the hand, after its course through the snuff box where its pulsations can be felt, it passes under the extensor pollicis longus tendon, then between the heads of the first dorsal interosseous muscle to enter the deep palm. Here, it forms the deep palmar arch by anastomosing with the deep palmar branch of the ulnar artery. This deep arch lies proximal to the superficial arch and deep to the long flexor tendons. It gives off branches like the arteria radialis indicis for the lateral side of the index finger and the arteria princeps pollicis for the thumb. It also contributes to the dorsal carpal arch on the dorsum of the hand.
Arterial injuries are serious, but the extensive collateral circulation around the shoulder, elbow, and wrist joints is a lifesaver. It means that even if a major artery is ligated, tissue necrosis or gangrene isn't an inevitable outcome, provided the collateral vessels are healthy and can expand to take over the blood supply. It can, however, take days or even weeks for these collateral pathways to fully open and compensate. Clinicians also need to know the specific palpable sites for arterial compression in emergencies to control bleeding. The subclavian artery can be compressed against the first rib of the root of the posterior neck, the axillary artery high in the armpit, the brachial artery in the midarm medial to the biceps, and the radial and ulnar arteries at the wrist.
A common clinical test to assess the patency of the arteries supplying the hand is Allen's test. This assesses the patency of both the ulnar and radial arteries. By compressing one artery and having the patient clench and open their fist, you can determine if the other artery alone can adequately perfuse the entire hand, crucial before certain procedures like arterial lines. Finally, it's important to remember that the arteries of the upper limb are innervated by sympathetic nerves originating from spinal cord segments T to 8. These postganglionic fibers travel with the brachial plexus branches and innervate the smooth muscle in the arterial walls, regulating vasomotor tone, essentially controlling whether the vessels constrict or dilate. In vasospastic diseases like Raynaud's phenomenon, where excessive constriction restricts blood flow, a cervicodorsal preganglionic sympathectomy, a surgical procedure to cut specific sympathetic nerves, might be performed to increase blood flow by reducing the sympathetic constriction.
Now, onto the veins, the return lines of the upper limb circulatory system. They are generally divided into two main groups, superficial and deep veins. The superficial veins lie, as their name suggests, in the superficial fascia just beneath the skin and are readily visible. They begin with the dorsal venous arch on the back of the hand, which then drains into the two major superficial veins, the cephalic and basilic veins. The cephalic vein arises from the lateral side of this dorsal venous arch, ascends up the lateral side of the forearm and arm, passes through the deltopectoral triangle, a small depression below the outer clavicle, and then finally drains into the axillary vein.
Crucially, the median cubital vein, which is a prominent, often large connecting branch of the cephalic vein in the cubital fossa, runs upward and medially to join the basilic vein. This particular vein is a very common and preferred site for venipuncture, drawing blood, and intravenous fluid administration due to its accessibility, relatively large size, and the protection offered to the underlying brachial artery and median nerve by the bicipital aponeurosis. The basilic vein arises from the medial side of the dorsal venous arch, ascends up the medial side of the forearm and arm, eventually piercing the deep fascia in the midarm to join the venae comitantes, accompanying veins, of the brachial artery, forming the axillary vein.
The axillary vein itself is formed at the lower border of the teres major muscle by the union of the brachial venae comitantes and the basilic vein. It then runs upward, typically medial to the axillary artery, and ends at the lateral border of the first rib, where it transitions into the subclavian vein. Like the arteries, the veins also have smooth muscle in their walls, innervated by sympathetic postganglionic fibers, providing essential vasomotor tone to regulate blood return.
Clinically, superficial veins are absolutely vital for various procedures: intravenous access, blood transfusions, and central venous catheterization. While the median cubital vein is a popular choice for routine IVs for central venous access, the basilic vein is often preferred. This is because it increases in diameter as it ascends the arm and aligns directly in line with the axillary and subclavian veins, making it easier to thread a long catheter into the central circulation. The cephalic vein is generally less suitable for this purpose due to its tendency not to increase significantly in size and its somewhat sharp right-angled junction with the axillary vein. Spontaneous thrombosis or clotting of the axillary vein, sometimes known as effort thrombosis, can also occur after excessive or repetitive arm movements, a condition often seen in athletes or those performing strenuous overhead work.
So we've tracked the intricate arterial supply and the venous return. Now let's explore the third crucial component of the upper limb circulatory system. Its dedicated drainage network for cellular waste, interstitial fluid, and immune surveillance, the lymphatics. All the lymph vessels in the upper limb ultimately drain into an extensive and strategically located network of axillary lymph nodes.
These axillary lymph nodes, typically numbering between 20 and 30, are incredibly important hubs of the lymphatic system. They collect lymph from a vast and critical territory, including the lateral quadrants of the breast, a key pathway for breast cancer metastasis, as we discussed, the superficial lymph vessels from the thoraco-abdominal walls above the umbilicus, the skin of the back above the iliac crests, and of course the entirety of the upper limb. They're meticulously organized into 6 distinct functional groups, each with specific drainage patterns: the anterior pectoral group, posterior subscapular group, lateral group, central group, infraclavicular deltopectoral group, and the apical group.
And the drainage pattern to these groups is quite specific and clinically relevant. The anterior group, located lower and deep to the pectoralis minor muscle, receives lymph primarily from the lateral breast and the anterolateral abdominal wall. The posterior group, situated in front of the subscapularis muscle, collects superficial lymph from the back, including the scapular region. The lateral group, positioned along the medial side of the axillary vein, receives the vast majority of the lymph from the entire upper limb, with the notable exception of those superficial vessels specifically draining the lateral side of the arm.
The central group, as its name suggests, is situated in the very heart of the axilla, embedded in axillary fat. It acts as a crucial collection point, receiving lymph from the anterior, posterior, and lateral groups. The infraclavicular nodes, also known as the deltopectoral nodes, are located outside the true axilla, specifically in the deltopectoral groove, between the deltoid and pectoralis major muscles. These nodes uniquely receive superficial lymph vessels from the lateral side of the hand, forearm, and arm, often following the course of the cephalic vein. Finally, the apical group, situated at the apex of the axilla, near the lateral border of the first rib, is the final relay station within the axilla. It receives efferent lymph flowing out, from all the other axillary nodes. These apical nodes then drain into the subclavian lymph trunk, which either joins the thoracic duct on the left side of the body or the right lymph trunk on the right side, or occasionally drains directly into large neck veins, returning the lymph to the bloodstream.
This detailed understanding of the axillary lymph nodes and their drainage pathways is absolutely critical for clinicians. For instance, a thorough examination of these nodes is a standard and essential part of any breast examination, particularly due to the high risk of breast cancer metastasis to these nodes. Clinicians systematically palpate the anterior, posterior, lateral, and central nodes to check for enlargement or tenderness. Then, with the patient relaxed, the examiner's fingers reach high up into the axilla towards the first rib to gently feel for the apical nodes.
The lymph drainage pathways of the upper limb are also divided into superficial and deep vessels. The superficial vessels, which drain the superficial tissues, primarily pass upward to the axilla. Those from the thumb, lateral fingers, and the lateral side of the hand, forearm, and arm follow the course of the cephalic vein to the infraclavicular nodes. Conversely, the lymphatic vessels from the medial fingers and the medial side of the hand and forearm typically follow the course of the basilic vein to the cubital fossa. Here, some drain into a small, clinically important supratrochlear node located just above the medial epicondyle, while others bypass it, accompanying the basilic vein directly to the lateral axillary nodes. The deep lymphatics, which drain the muscles, bones, and other deep structures of the upper limb, ultimately flow into the lateral group of axillary nodes.
Infections of the lymph vessels themselves, known as lymphangitis, are common and often present clinically as characteristic red streaks visible along their course. And once the infection reaches the lymph nodes, they become enlarged, tender, and sometimes painful, a condition called lymphadenitis. This explains why inflammatory edema or even abscess formation frequently occurs on the dorsum of the hand after an infection originating in the fingers or palm. Most lymph from these distal areas initially passes to the dorsum of the hand before ascending the forearm, making the dorsum a common site for visible inflammatory signs. Now that we've covered the bones, muscles, nerves, and vessels, let's articulate how it all connects and moves. We're talking about the joints of the upper limb. There are numerous joints, almost all of them synovial, allowing for incredible mobility, making this an exceptionally versatile and intricate limb.
Starting proximally, we have the sternoclavicular joint, a crucial connection point. This is where the sternal, or medial end of the clavicle, meets the manubrium sterni and the first costal cartilage. It's classified as a synovial double plane joint, unique because it features a fibrocartilaginous articular disc that completely divides its interior into two separate compartments. This joint is heavily reinforced by extremely strong ligaments. The sternoclavicular ligaments, located anteriorly and posteriorly, and a very strong accessory ligament called the costoclavicular ligament, which runs from the first rib and its costal cartilage up to the inferior surface of the clavicle.
The movements permitted at the sternoclavicular joint involve forward and backward gliding of the clavicle within the medial compartment, and elevation and depression of the clavicle within the lateral compartment. Due to the immense strength of that costoclavicular ligament, clavicle fractures are actually far more common than dislocations of this joint. But if a dislocation does occur, an anterior dislocation can cause the clavicle to project forward and upward, creating a visible bump. A posterior dislocation, however, is much more serious, as the displaced clavicle can press on vital structures in the neck, such as the trachea, esophagus, and major blood vessels, potentially leading to life-threatening complications.
Moving laterally, we encounter the acromioclavicular joint, where the acromion process of the scapula articulates with the lateral end of the clavicle. This is a synovial plane joint allowing primarily gliding movements. It's strengthened by superior and inferior acromioclavicular ligaments. However, the most critical stabilizing structure for this joint is the extremely strong coracoclavicular ligament. This accessory ligament extends from the coracoid process of the scapula to the undersurface of the clavicle. It plays a pivotal role in suspending the entire weight of the scapula, and indeed the entire upper limb from the clavicle, and is fundamental for transmitting forces and facilitating the rotary movements of the scapula during arm elevation.
So if you're in a situation like a severe blow on the point of the shoulder, often seen in contact sports, it can result in the acromion being forcefully thrust beneath the clavicle. This action often tears that crucial coracoclavicular ligament, leading to what is commonly known as a shoulder separation. The displaced outer end of the clavicle is often easily palpable, creating a characteristic deformity. While it might be easy to reduce this dislocation, it often redislocates without proper external support, because that primary stabilizing ligament, the coracoclavicular, is torn.
Now to the glenohumeral joint, or shoulder joint, which is absolutely central to understanding our patient's case. This is where the large rounded head of the humerus articulates with the shallow, pear-shaped glenoid cavity of the scapula. This cavity is slightly deepened by a fibrocartilaginous rim called the glenoid labrum, which enhances stability without greatly restricting movement. It's a synovial ball and socket joint, uniquely designed for an incredibly wide range of movement, truly making it the most mobile joint in the body, but this comes at a cost. Stability is significantly sacrificed for mobility.
Its capsule is famously thin and lax, which is what allows for such extensive movement, but it's fundamentally strengthened by fibrous slips from the tendons of the surrounding rotator cuff muscles. The subscapularis, supraspinatus, infraspinatus, and teres minor. Ligaments like the glenohumeral ligaments, 3 weak bands on the anterior aspect, the transverse humeral ligament, which holds the biceps tendon in its groove, and the coracohumeral ligament, which strengthens the capsule superiorly, provide some reinforcement. An important accessory ligament is the coracoacromial ligament, which forms an arch above the joint, protecting its superior aspect. The joint itself is richly innervated by branches from the axillary and suprascapular nerves, making it exquisitely sensitive to pain.
The movements here are incredibly extensive. Flexion, extension, abduction, adduction, lateral rotation, medial rotation, and circumduction. Abduction, for example, is initiated by the supraspinatus muscle, which holds the humeral head firmly in the glenoid fossa and starts the movement, allowing the powerful deltoid muscle to then take over and continue abducting the arm. The scapular humeral mechanism, or scapulohumeral rhythm, describes the synchronized movement of the shoulder joint and the scapula during arm elevation. For every 3 degrees of arm abduction, approximately 2 degrees occur at the shoulder joint and 1 degree by rotation of the scapula. At around 120 degrees of abduction, the greater tuberosity of the humerus comes into contact with the acromion, and any further elevation requires external rotation and upward rotation of the scapula.
This joint's inherent instability, due to the shallow glenoid cavity and relatively weak ligaments, is almost entirely compensated for by the dynamic tone of the rotator cuff muscles, but its weakest point is inferiorly, where it's largely unprotected by muscles. This makes it, alarmingly, the most commonly dislocated large joint in the body.
And this is absolutely critical for understanding our patient's injury. An anterior-inferior dislocation, which our patient experienced, typically results from sudden forceful violence with the arm in full abduction and often external rotation. In this position, the humeral head tilts downward onto the weak inferior part of the joint capsule, tearing it. The humeral head is then often pulled forward and upward into a subcoracoid position by the strong pull of flexor and adductor muscles. Less commonly, posterior dislocations can occur, usually from direct violence to the front of the shoulder. Clinically, a shoulder dislocation results in a noticeable loss of the normal rounded shoulder appearance. The deltoid muscle no longer has the greater tuberosity of the humerus bulging laterally beneath it, so the shoulder appears flattened, and a palpable gap may be present below the acromion. For our patient, the humerus was displaced medially, further contributing to this loss of normal contour. Furthermore, subglenoid displacement during such a dislocation can stretch and damage the axillary nerve, leading to deltoid paralysis and sensory loss over the lower deltoid, a precise match for part of our patient's symptoms. Downward displacement of the humerus can also stretch and damage the radial nerve, explaining another significant part of her widespread sensory deficits.
Shoulder pain itself can be a complex diagnostic challenge. While the joint is highly sensitive to pain and pressure from direct injury, pain can also be referred to the shoulder from other seemingly unrelated areas. For example, irritation of the diaphragmatic pleura or peritoneum can send pain signals via the phrenic and supraclavicular nerves to be perceived in the shoulder. So conditions like pleurisy, peritonitis, a subphrenic abscess, or even gallbladder disease can all cause shoulder pain, even if the shoulder joint itself is perfectly normal and unaffected.
Moving distally, the elbow joint is a classic synovial hinge joint formed by the articulation of three bones, the trochlea and capitulum of the humerus proximally, the trochlear notch of the ulna, and the head of the radius distally. Its joint capsule is weak anteriorly and posteriorly, but it is incredibly strongly reinforced by robust collateral ligaments, the lateral radial collateral ligament and the medial ulnar collateral ligament, the latter having three strong bands, anterior, posterior, and transverse. The elbow joint is richly innervated by articular branches from the median, ulnar, musculocutaneous, and radial nerves.
The elbow primarily allows for two main movements, flexion and extension. Flexion is performed by the brachialis, biceps brachii, brachioradialis, and pronator teres, and it's limited by the soft tissues of the arm and forearm meeting. Extension, performed by the triceps brachii and anconeus, is checked by the anterior ligament and the old cranon entering its fossa. The carrying angle, the slight valgus angle the forearm makes with the arm in extension, is about 170 degrees in males and 167 degrees in females. It actually disappears in full flexion as the forearm aligns with the arm.
The elbow joint is inherently stable, largely due to the wrench-shaped bony configuration of the olecranon and trochlea and its incredibly strong collateral ligaments. This bony stability is clinically assessed. In full extension, the medial and lateral epicondyles of the humerus and the olecranon process of the ulna normally form a straight line. In flexion, they form an equilateral triangle. Any deviation from this pattern indicates potential dislocation or fracture. Elbow dislocations are relatively common, especially posterior ones, often occurring in children due to their incomplete bone development. Avulsion of the medial epicondyle epiphysis is also a common childhood injury, often associated with elbow dislocation. Swelling within the joint can be aspirated, removed from either side of the olecranon. Crucially, the ulnar nerve is highly vulnerable in elbow injuries due to its close relation to the medial epicondyle. It can be injured immediately during dislocations or fractures, or weeks, months, or even years later due to scar tissue formation, chronic stretching, or friction in its groove. Radiology of the elbow often shows the lower end of the humerus angled forward at 45 degrees, with the medial epicondyle facing medially and posteriorly.
Then there are the radial nerve joints, which are critical for the movements of pronation and supination. The proximal radial nerve joint articulates the head of the radius with the annular ligament and the radial notch of the ulna. It's a synovial pivot joint, and its capsule is continuous with the elbow joint capsule. The annular ligament forms a collar around the radius head, but is not directly attached to it, allowing the radius head to rotate freely within it. Because of this continuity, an infection in the elbow joint will always involve this proximal radial nerve joint. A common childhood injury here is nursemaid's elbow, or transient subluxation of the radial head, caused by a sudden jerk on a child's pronated arm, which pulls the radial head partially out of the annular ligament.
The interosseous membrane is a strong, fibrous ligament uniting the shafts of the radius and ulna along their interosseous borders. Its obliquely oriented fibers serve two crucial functions. They resist proximal displacement of the radius relative to the ulna, and they transmit forces from the radius, where forces from the hand are typically received, to the ulna, and then up to the humerus. This membrane is taught in the mid-prone position, often referred to as the position of function, ensuring maximal stability for gripping. The distal radial nerve joint, located at the wrist, articulates the head of the ulna with the ulnar notch of the radius. It's also a synovial pivot joint, but crucially, a triangular articular disc separates it from the main wrist joint, meaning it does not communicate with the wrist joint directly.
Pronation and supination are complex rotary movements involving both radial nerve joints simultaneously. In pronation, the head of the radius rotates within the annular ligament at the proximal joint, while the distal end of the radius, along with the hand, moves forward, causing the palm to face posteriorly. The ulnar notch of the radius rotates around the head of the ulna at the distal joint. The ulna itself remains relatively stable, moving only slightly laterally to keep the hand in line. The pronator teres and pronator quadratus muscles are responsible for this action. Supination is the direct reversal of these movements, returning the hand to the anatomical position, with the palm facing anteriorly. It's a more powerful movement, driven primarily by the biceps brachii and supinator muscles. Think about using a screwdriver. A right-handed person typically supinates their right forearm to drive a screw in, highlighting the power of supination.
From a clinical perspective, understanding radial joint disease is important. As mentioned, the proximal joint communicates with the elbow, so elbow infections can spread. But the distal joint separation from the wrist by the articular disc prevents direct spread of infection between those two.
Finally, the wrist joint, or radiocarpal joint, which is a pivotal connection. It articulates the distal radius and its articular disc, which separates the ulna from the wrist, with the proximal row of carpal bones, specifically the scaphoid, lunate, and triquetral. It's a synovial ellipsoid joint, permitting a wide range of movements: flexion, extension, abduction, radial deviation, adduction, ulnar deviation, and circumduction. However, it allows no true rotation. Any perceived rotation is actually compensated for by the pronation and supination movements of the forearm.
Its movements are quite extensive. Flexion is performed by the flexor carpi radialis, flexor carpi ulnaris, and palmaris longus muscles, assisted by the long finger and thumb flexors. Extension is performed by the extensor carpi radialis longus and brevis, and extensor carpi ulnaris, assisted by the long finger and thumb extensors. Abduction, radial deviation, is performed by the flexor carpi radialis and the extensor carpi radialis longus and brevis, assisted by the abductor pollicis longus and extensor pollicis longus and brevis. Adduction, ulnar deviation, is performed by the flexor carpi ulnaris and extensor carpi ulnaris. The wrist joint is stabilized by strong medial and lateral collateral ligaments. Because the styloid process of the radius extends further distally than that of the ulna, abduction, radial deviation, is mechanically less extensive than adduction, ulnar deviation. Flexion at the wrist is typically around 80 degrees, while extension is about 45 degrees, with the mid-carpal joint contributing to further flexion range. Falls on an outstretched hand can lead to significant injuries here, often involving a strain of the anterior ligament, causing synovial effusion, pain, and limited movement, which must be differentiated from more serious injuries like scaphoid fracture or lunate dislocation. The pattern of age-related injuries from such falls is fascinating and almost diagnostic. In a young child, it might be posterior displacement of the distal radial epiphysis. In a teenager, a clavicle fracture. In a young adult, a scaphoid fracture. And in the elderly, commonly a Call's fracture of the distal radius about an inch proximal to the wrist. This context is important for understanding our patient's potential age-related vulnerabilities, though her primary injury was a shoulder dislocation.
Moving to the truly intricate hand and finger joints. We have the intercarpal joints, which are between the individual carpal bones within each row, and the midcarpal joint, which is between the proximal and distal rows of carpals. All are synovial plane joints, allowing for small gliding movements. Similarly, the carpometacarpal and intermetacarpal joints, except for the thumb, are also synovial plane joints with limited gliding movement.
But the carpometacarpal joint of the thumb is unique and essential. It's formed between the trapezium bone and the saddle-shaped base of the first metacarpal. This is a synovial saddle joint, and its specific configuration allows for the thumb's unparalleled range of motion. Flexion by the flexor pollicis brevis and opponens pollicis, extension by the extensor pollicis longus and brevis, abduction by the abductor pollicis longus and brevis, adduction by the adductor pollicis, and most critically, rotation and opposition, primarily by the opponens pollicis. This opposition is what allows for the sophisticated pincer action that distinguishes the human hand.
The metacarpophalangeal joints, where the rounded heads of the metacarpals meet the bases of the proximal phalanges, are synovial condyloid joints. They permit flexion by the lumbricals interossae, assisted by the flexor digitorum superficialis and profundus, extension by the extensor digitorum indicis and digiti minimi, abduction by the dorsal interossae and the abductor digiti minimi, and adduction by the palmar interossae. Importantly, abduction and adduction of the fingers are only truly possible in the extended position because the collateral ligaments become taut in flexion, effectively locking out these movements. Then there are the interphalangeal joints, proximal and distal, which are classic synovial hinge joints. They are structurally similar to the MCPs, but only allow for flexion and extension, not abduction or adduction. This entire chain of joints, each with its unique characteristics and range of motion, grants the hand its incredible dexterity and functional range. All right, let's tie all these intricate parts together into the functional masterpiece that is the hand. This isn't just the distal end of the upper limb. It's a prehensile organ whose entire importance and functional capability center on the pincer-like opposable action of the thumb. That thumb, in its unique mobility and dexterity, is almost as important as all the other fingers combined, allowing us to grasp, manipulate, and interact with our environment with unparalleled precision.
It's a true marvel of evolution and biomechanical design. To appreciate the hand's capabilities fully, we often describe its position of rest and its position of function. In the position of rest, when the hand is completely relaxed, the forearm is typically semi-prone, the wrist is slightly extended, and the fingers are partially flexed, though the index finger tends to be slightly less flexed than the others. The plane of the thumbnail lies roughly at a right angle to the planes of the other nails.
But the position of function is the key to understanding its active capabilities, particularly for grasping and manipulation. Here, the forearm is also semi-prone, but the wrist joint is partially extended, often more so than at rest. All the fingers are partially flexed, crucially, including the index finger, as much as the others. The thumb is specifically rotated and positioned so its thumbnail is parallel to the index finger, and the pulp of the thumb and index finger are poised for contact, ready for that precise pincer grip.
The wrist's partial extension in the position of function is absolutely critical. It puts the long flexors and extensors of the fingers at their optimal mechanical advantage, ensuring a stable and powerful base for the intricate and delicate movements of the fingers and thumb. This synergy of wrist and finger positioning allows for both maximum power and unparalleled precision. The thumb itself has 5 distinct and complex movements. Flexion moves the thumb across the palm, with the thumbnail plane remaining at right angles to the other nails. Muscles involved include the flexor pollicis longus, flexor pollicis brevis, and opponens pollicis. Extension moves the thumb laterally, or in the coronal plane, away from the palm, again with the thumbnail plane at right angles, extensor pollicis longus and brevis. Abduction moves the thumb antero-posteriorly, away from the palm, maintaining the right angle nail plane, abductor pollicis longus and brevis. Adduction moves it antero-posteriorly toward the palm, adductor pollicis. But most crucially, there is opposition. Opposition is a complex, compound movement that involves not just flexion and abduction, but a unique medial rotation of the first metacarpal on the trapezium. This allows the anterior tip of the thumb to contact the anterior surface of the tip of any other finger, with the thumbnail becoming parallel to the other nails. This exquisite coordinated movement is the foundation of our manipulative ability, enabling the pincer action.
The other fingers, the index, middle, ring, and little fingers, also have specific movements vital for their collective function. Flexion moves the finger forward in an anteroposterior plane, a coordinated action where the distal phalanx is flexed by the flexor digitorum profundus, the middle phalanx by the flexor digitorum superficialis, and the proximal phalanx by the lumbricals and interossae. Extension moves them backward in the anteroposterior plane, distal and middle phalanges by lumbricals and interossae acting through the extensor expansion, and proximal phalanges by the extensor digitorum, indiges, and digiti minimi. Abduction moves the fingers away from the imaginary midline of the middle finger, primarily by the dorsal interossae and the abductor digiti minimi. Adduction moves them toward the midline of the middle finger, by the palmar interossae. It's important to remember that abduction and adduction of the fingers are only truly possible when the metacarpophalangeal joints are in the extended position due to the specific tension of the collateral ligaments.
When you cup your hand, you're creating a deep concavity in your palm, essential for holding liquids or small objects. This intricate action involves the thumb being abducted, partially opposed and slightly flexed, which draws the thenar eminence forward. Simultaneously, the 4th and 5th metacarpals flex and rotate at their carpometacarpal joints, bringing the hypothenar eminence forward and inward. The small palmaris brevis muscle contracts, subtly puckering the skin on the hypothenar eminence to improve grip. The fingers also partially flex and slightly rotate, all enhancing that cup shape.
And when you make a fist, you're performing a powerful coordinated action involving the flexion of all the metacarpophalangeal and interphalangeal joints of your fingers and thumb. For a strong and effective fist, a synergistic contraction of the wrist extensors, muscles like the extensor carpi radialis longus and brevis, and the extensor carpi ulnaris, is absolutely essential. These muscles work to extend the wrist joint, counteracting the powerful flexion forces of the finger flexors. You simply cannot make a truly powerful fist with a flexed wrist. The mechanics are compromised and the flexors become less efficient.
From a clinical standpoint, the hand's function is paramount to a person's quality of life and often their livelihood. Therefore, preserving the thumb and its pincer action is frequently the primary goal in the management of hand injuries or reconstructive surgeries. This pincer action, however, isn't solely about muscle movement. It critically relies on tactile sensation in the thumb and opposing fingers. This explains why a median nerve palsy, which leads to a devastating loss of sensation in those critical lateral fingers and the inability to oppose the thumb, is considered so much more disabling than an ulnar nerve palsy, where lateral sensation and a reasonable pincer grip often remain. If the hand must be immobilized, such as after injury or surgery, it should ideally always be placed in the position of function to maximize its mechanical advantage and minimize long-term stiffness if movement is lost. And clinicians always refer to the fingers by their specific names: thumb, index, middle, ring, little finger, to avoid any ambiguity in diagnosis or treatment.
Let's take a brief but absolutely fascinating detour into how this incredible marvel, the upper limb, actually develops in the first place. This embryonic journey not only explains the limb's complex adult structure, but also gives us profound insights into some of the congenital anomalies that can occur. The earliest signs of our arms and legs, known as limb buds, appear during the 6th week of embryonic development. They begin as localized proliferations of mesenchyme, which cause the overlying ectoderm to bulge outwards from the trunk. The arm buds, remarkably, develop slightly before the leg buds and are associated with the lower 6 cervical, C5, C6, C7, C8, and upper 2 thoracic, T1, T2 spinal cord segments.
This localized mesenchyme then undergoes intricate organization, differentiating into distinct anterior and posterior groups, which will form the flexor and extensor compartments of the limb, respectively. Simultaneously, the growing spinal nerves originating from those C5 to T1 segments also divide and extend into these developing limb buds, following these anterior and posterior pathways. As the mesenchyme differentiates into individual muscles that then migrate to their final positions, these delicate nerve trunks become intricately arranged into complex plexuses, ultimately forming the brachial plexus at the base of the upper limb. This precise and beautifully choreographed developmental process, while usually flawless, can sometimes go awry, leading to a range of congenital anomalies.
Indeed, we can see conditions like amelia, which is the total congenital absence of a limb, or ectromelia, where there is a partial absence of a limb. Phocomelia is a particularly striking and rare form, where a rudimentary or even a well-developed hand springs directly from the shoulder, with the intermediate limb portion, arm and forearm, completely missing. Sometimes there's a congenital absence of the radius bone, which leads the ulna to push the hand laterally, resulting in a radial club hand deformity.
Other congenital anomalies include syndactyly, or webbing of the fingers, where the digits fail to separate completely. This condition is often bilateral and familial, sometimes presenting as a more severe lobster hand deformity with a central cleft. Brachydactyly involves the congenital absence or shortening of one or more phalanges, leading to abnormally short fingers or toes. A floating thumb is a very specific anomaly where the metacarpal bone of the thumb is absent, but the phalanges of the thumb are present, leading to a floppy, non-functional thumb. Polydactyly refers to the presence of extra digits, a relatively common anomaly. And macrodactyly is a rare condition of local gigantism, where one or more digits are abnormally large due to overgrowth of all the tissues. Understanding these developmental variations helps clinicians not only diagnose these conditions, but also plan complex corrective surgeries to improve function and quality of life for affected individuals.
To truly master our understanding of the upper limb, we also need to know how to see what's invisible beneath the skin and feel what's accessible on the surface. This takes us into the critical realms of radiographic and surface anatomy. Conventional X-rays, for instance, are invaluable for primarily showing us the bony structures, as muscles, tendons, and nerves blend into a largely homogeneous mass. Magnetic resonance imaging, or MRI on the other hand, is exquisitely useful for visualizing those soft tissues around the bones, providing detailed images of muscles, tendons, ligaments, and nerves, which X-rays cannot.
Absolutely. And then there's surface anatomy, a fundamental skill in clinical practice, which involves locating and identifying key underlying structures by simple palpation and observation. On the anterior chest and shoulder, you can easily feel the suprasternal notch at the top of the sternum and trace the entire length of the clavicle, identifying both its sternoclavicular and acromioclavicular joints. The deltopectoral triangle is a small, often visible depression just below the outer clavicle, bounded by the pectoralis major and deltoid muscles. The anterior axillary fold is formed by the lower margin of the pectoralis major, and the posterior axillary fold by the latissimus dorsi and teres major muscles.
In the axle itself, with the arm supported, you can palpate the inferior part of the humeral head, feel the pulsations of the axillary artery high up against the humerus, and, with careful palpation, even discern the cords of the brachial plexus around the artery. The upper ribs, covered by the serratus anterior muscle, form the medial wall. And in a muscular person, you can sometimes see and feel the distinct serrations of the serratus anterior when the arm is abducted. The coracobrachialis and biceps muscles form part of the lateral wall.
Moving to the posterior shoulder, you can palpate the spinous processes of the cervical and thoracic vertebrae, with C7, the vertebra prominens, being the most prominent at the base of the neck. The scapula offers numerous palpable landmarks. The tip of the coracoid process felt deep in the deltopectoral triangle, the subcutaneous acromion, which forms the tip of the shoulder, the smooth curve of the deltoid muscle over the greater tuberosity of the humerus, the prominent crest of the scapular spine, and the superior and inferior angles of the scapula, the latter typically opposite the T7 spinous process. Breast anatomy is also important on the surface. Its size and shape vary considerably, and the nipple is often located over the fourth intercostal space in males or immature females, surrounded by the pigmented areola with its characteristic raised areolar glands, or tubercles of Montgomery. Its consistency should be stained and lobulated.
Around the elbow region, the bony landmarks are particularly clear and clinically significant. The medial and lateral epicondyles of the humerus and the olecranon process of the ulna are all readily palpable. In full extension, these three bony points form a straight line, which is a key clinical observation for assessing elbow alignment. In full flexion, they form an equilateral triangle. The head of the radius can be palpated in a depression posterolateral to the extended elbow and felt to rotate during pronation and supination of the forearm, which is a test for its mobility and integrity. The cubital fossa is a visible triangular depression anterior to the elbow, bounded by the brachioradialis and pronator teres muscles. You can palpate the strong biceps tendon descending into it, and the bicipital aponeurosis providing its roof. The ulnar nerve is distinctively palpable and exposed behind the medial epicondyle, producing that classic pins and needles sensation when compressed. The brachial artery's pulsations can be felt in the arm and within the cubital fossa, and the posterior border of the ulna is entirely subcutaneous and palpable along its entire length from elbow to wrist.
At the wrist and hand, there are many more palpable landmarks that are essential for examination. The styloid processes of the radius and ulna are easily felt distally, with the radial styloid typically about 0.75 inches distal to the ulnar styloid. The dorsal tubercle of the radius, a small bony prominence, is located on the posterior surface of the distal radius. The head of the ulna becomes particularly prominent on the dorsum of the wrist in full pronation. The pisiform bone, a small carpal bone, is felt on the medial anterior wrist, embedded in the flexor carpi ulnaris tendon. The hook of the hamate can be felt with deep palpation, approximately 1 finger breadth distal and lateral to the pisiform. The transverse creases of the wrist are also important. The proximal crease indicates the level of the wrist joint, and the distal crease corresponds to the proximal border of the flexor retinaculum.
On the anterior wrist, several key structures are palpable. You can feel the pulsations of the radial artery lateral to the prominent flexor carpi radialis tendon. The tendons of the flexor carpi radialis, the palmaris longus, if present, forming a strong central cord, and the flexor digitorum superficialis are all palpable. The flexor carpi ulnaris tendon is the most medial and strongest wrist flexor. The ulnar artery's pulsations can be felt lateral to the flexor carpi ulnaris tendon, with the ulnar nerve lying immediately medial to it. On the lateral side of the wrist, the anatomical snuff box is a key area. You can palpate the scaphoid and trapezium bones in its floor, and crucially, feel the radial artery pulsating within this space.
On the back of the wrist, the lunate bone can be palpated just distal to the dorsal tubercle of the radius when the wrist is flexed. In the palm, the course of the recurrent branch of the median nerve can be approximated about 1 finger breadth distal to the scaphoid tubercle. The superficial palmar arterial arch typically lies across the palm at the level of the distal border of the fully extended thumb, while the deeper palmar arch is located more proximally at the level of the proximal border of the fully extended thumb. The metacarpophalangeal, MCP, and interphalangeal IP joints align with their respective skin creases on the palmar surface. Finally, on the dorsum of the hand, the tendons of the extensor digitorum, extensor indicis, and extensor digiti minimi are clearly visible and palpable, particularly when the fingers are extended. The dorsal venous network, which drains into the cephalic and basilic veins, is also often prominent, especially after exercise. The median cubital vein connecting these two is a key landmark in the cubital fossa. Learning to accurately identify these surface landmarks and what lies beneath them is fundamental for clinical examination, precise diagnosis, and accurately pinpointing potential injury sites or areas of pathology. #STAG outro. What's truly fascinating here, and what we hope you've come to master, is how every single detail we've explored, from the unique S shape of the clavicle to the delicate yet tightly packed arrangement of the carpal tunnel, played a specific, predictable role in understanding our patient's symptoms. The observable loss of shoulder curvature, those incredibly specific patterns of sensory deficits, these were not random, isolated findings. They were direct, predictable consequences of precise anatomical relationships and their traumatic disruption. The skeletal integrity defines the joint mechanics, the muscles execute every movement, the nerves precisely control both sensation and action, and the vessels relentlessly sustain it all. Disruption at any level creates a cascading series of effects, which, with this deep understanding of anatomy, transforms from a perplexing mystery into a clear, decipherable diagnostic picture.
So what does this all mean for our 64-year-old patient who took that terrible fall? Her incident caused a subcoracoid dislocation of the shoulder joint. This meant her humeral head, instead of sitting securely within the shallow glenoid cavity, was forcefully displaced downward and then pulled forward and upward, coming to rest inferior to the coracoid process of the scapula. This displacement was exacerbated by the powerful unopposed pull of muscles, like the subscapularis and pectoralis major. That striking loss of the normal rounded shoulder curvature. It was caused by the greater tuberosity of the humerus being displaced medially, so it no longer protruded laterally beneath the deltoid muscle, making her shoulder appear visibly flattened and squared off. And that extensive, severe sensory loss across her upper limb, the precise pattern we meticulously described. It was a clear, undeniable fingerprint of damage to both her axillary and radial nerves. The axillary nerve, intimately associated with the surgical neck of the humerus and passing through the quadrangular space, was highly vulnerable to damage from the humeral head dislocation as it was violently shifted. Its injury accounts for the sensory loss over the lower half of her deltoid, on the lower lateral surface of her arm, precisely matching her report. The radial nerve, that workhorse nerve, which runs into the radial groove along the midshaft of the humerus, was likely stretched and directly damaged by the significant downward displacement of the humerus during the dislocation itself, or potentially involved in an occult fracture that wasn't immediately apparent. Its injury accounts for the widespread sensory loss on the back of her arm, the middle of the posterior forearm, the lateral half of the dorsal hand, and the dorsal surface of those lateral 3.5 fingers proximal to the nail beds. Every single symptom, however complex it initially appeared, can be precisely mapped back to specific anatomical structures and their inherent vulnerabilities when subjected to trauma.
This level of detailed understanding, this mastery of anatomical relationships, isn't just academic. It's the very foundation of clinical excellence and empowers anyone to truly grasp the body's mechanics. Understanding these intricate connections, how bones dictate movement, how muscles execute it, how nerves control both sensation and action, and how blood vessels sustain everything, this allows you to predict, interpret, and ultimately comprehend the processes of injury, disease, and healing. It's truly about seeing the whole picture, not just individual dots of information, and understanding how they dynamically interact in both health and disease. It's the profound difference between merely observing a symptom and understanding its root cause, its pathway, and its full clinical impact.
And as you go about your day, next time you reach for something or grasp a hand or even just scratch your elbow, take a moment to consider the silent symphony of bones, muscles, nerves, and vessels working in perfect yet incredibly fragile harmony within your own arm and hand. Think about that single fall, that cascade of events, and the incredible detail required to put the puzzle back together. What other everyday actions might reveal the hidden vulnerabilities, the extraordinary resilience, and the sheer engineering genius of your own intricate anatomy?